Sasikala, how are you?
It's fine. Now live.
Hi.
We are live.
Good, thank you.
Hello.
Namaskar, Sasikala ma'am.
Namaste, sir. Namaste.
So we are live, Nisha.
Yes, we are live now.
So start, Babita. Now live.
Hi.
We are live, ma'am.
Start. Babita, you start.
Yes, ma'am. Yes. Okay. So shall we go live now?
Yeah, we
Yeah,
are
we
live.
are already live.
Live. Okay. So, good evening to all esteemed faculties and respected delegates. It is an immense pleasure to address this August gathering on the occasion of the second series of Yuva ISOPARB educational webinar. Dr. Sadhna ma'am's attempt of bringing forward young and budding gynecologists is commendable. She believes youth is full of fresh thoughts and innovative ideas. So, including their views on is
रीना जी अनम्यूट कर लीजिए.
of our seat with your picks.
रीना जी अनम्यूट कर.
म्यूट करना है.
Today's webinar is optimizations in obstetrics. It seems
Unmuted
to be
तो है.
really a very interesting topic. Interventional obstetrics helps us to improve the outcome in complicated pregnancies. We look forward to
रीना
an
मैम
interesting
म्यूट कर लीजिए.
We look forward to an interesting scientific session today. Before starting this auspicious session, let us all remember Lord Ganesha, Vignaharta, to remove all obstacles on our way. Let us join hands for Ganesh Vandana. So Nisha, kindly. Nisha, I hope you're there.
Yes, ma'am, sharing.
Yes.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Now, I would like to take the opportunity to invite all our esteemed faculties to join us for the lighting of the lamp. Nisha? May Ma Saraswati bless us and enlighten our lives with the light of knowledge. Thank you, Nisha. With immense pleasure and pride, I would like to invite Dr. Reena Srivastav, Pride of GOGS. Ma'am is requested to invite our chief guest of the evening, Professor Gangadhar Sahu. Dr. Reena Srivastav is ex-professor and HOD BRD Medical College.
Okay, Babita.
Ma'am, just a minute. Thoda bolnu. Past President UP Chapter, ex-President Gorakhpur Menopause Society, fellow ICOG. Ma'am has organized several conferences and authored chapters in books. She has several publications to her credit, and she has received several awards also. A warm welcome to you, ma'am, and kindly invite our chief guest of the evening, Professor Gangadhar Sahu.
Thank you, Babita, for the kind words. I'm delighted to say a few words about Dr. Gangadhar Sahu, who is decorated with so many human laurels, like he's a proactive and progressive grassroots ISOPARBian, a disciplined learner, a practical man and performer.
Nisha, kindly display the CV.
Loves accepting challenges, principles of life, live rich but don't die rich. Dream of life to be a ladder of success for others to climb up. Over and above an ordinary man surrounded by extraordinary well-wishers. With these decorations, he is retired Professor of OBGYN and HOD VSS Medical College, Burla, Sambalpur, ex-Dean IMS and some hospital, Bhubaneswar, ex-Pro VC SOA, deemed to be University, Bhubaneswar. At present, he is president of ISOPARB. And Dr. Gangadhar Sahu, I invite you for your words of wisdom. Everybody is waiting for it. Please.
Thank you, Rina madam. So my namaskar to all of you who are attending this webinar. My namaskar to Lord Jagannath. Blessings from Lord Jagannath and greetings from Odisha, particularly Bhubaneswar and Sambalpur. Dear special guest, Chilamane Madam, guest of honor, Dr. Milind Shah, and other participants. So I have given the task to give a message to the young and budding gynecologists and the obstetricians and the ISOPARBians. So what I will speak, it is from my own experience. 2 minutes I will take only. Since 1976, when I entered into the postgraduate course, I might be around 25, 26 years. So from that, I have seen my generation of youth, then the next generation of youth while I was a teacher, and now another generation. During this change in the generations, what I have personally experienced among the young doctors now, particularly those who are passing out, they are more or less running after the degree rather than the course itself, how to learn the technology, how to learn the academics, so on and so forth. That is one of my experiences or observations. Second thing I have learned and observed that patience is lacking in the modern young gynecologists. So other things I am not going to say. But the first criteria which needs or which is very much essential to be a doctor, that is almost also lacking. Therefore, I will focus on that point today. I always teach my students, whether undergraduate or postgraduate, that be a human being first, then a doctor. So the qualities of the human beings, so that is being taught in our homes, in our school career, in the colleges. So therefore, as it is a saying that charity begins at home. So might be there is some fault, whatever it may be. So what are the characteristics of a human being which is lacking in the modern practitioners or modern gynecologists or modern young doctors that I teach my students are the alphabets of life. A, B, C, D, E. A stands for attitude. You must have the attitude to be a doctor, to be a human being first. B, your behavior speaks volume of it. C, your character. D is discipline. I always say discipline is the key word of medical science and medical profession. Slightest indiscipline can cost a life. That should be taken as the mula mantra for a physician. And E is empathy. Without going to the level of the patient, without understanding the pain of the patient, without putting your hand on the patient, without listening patiently his or her complaints, we cannot understand what medical science is. Therefore, my message to the young budding doctors is, for today, it is be a human being first, then a doctor. Be a human being first, then a doctor. Be a human being first, then a doctor. My namaskar to all of you. Long live ISOPARB, long live ISOPARB, long live ISOPARB. Sarve bhavantu sukhina, sarve santu niramaya, sarve bhadrani pasyantu, ma kaschid dukha bhavet. Thank you very much for inviting me, Sadhana ma'am. And this is my message to all the budding gynecologists. Thank you very much.
Sir, you have made us really very emotional with such lovely messages. Thank you, sir, for your kind words. Lovely messages for the budding gynecologists that we should follow the path of humanity and we should be compassionate towards our patients. Your thoughts are as pure as the blessings of our Mahaprabhu, Lord Jagannath. Now, talking about the lady with a vision to take Foxy to the next level, with a mission to reach out to every society through her academic skills. She is a dedicated research worker, a hardcore academician. पहले साधना मैम का slide display करो निशा. Wonderful orator, organizer, and a trendsetter for the last 38 years in Foxy.
It's okay,
Ma'am, just a minute. Ma'am is co-chair. Nisha, please display the slide. Ma'am is co-chair Suffolk NCD committee. She is ICUG Governing Council member, National Correspondent Editor Jogi, Chairperson Safe Motherhood Committee. Talking about her academic excellence, 9 gold medals. Naval Kishore Gold Medal Award for Best Postgraduate Student, Best Governing Council Member Award, thrice Korean Award for the Best Scientific Research Paper, 4 times Best Research Paper Award in ICUG, and thrice DC Datta Prize for Foxy Publication. She has received several awards, be it the N.A. Pandit Award, the Mehru Hansotia Award, Dhuru Shah Award, R.N. Malhotra Award, and the Economic Times Award. We can go on and on and on. Organizer of several conferences. She has several publications to her credit, original research papers. The line which I would like to talk about her is, strong women aren't simply born. Strong women aren't simply born. They are made by the storms they walk through. A warm welcome to you, ma'am. Dr. Sadhana Gupta, ma'am. Ma'am, kindly grace the dais and welcome our special guest and guest of honor, Dr. Sheila Mani and Dr. Milinsha.
Thank you, Babita. It was too loving. So what I will keep the thread from the thing that whatever I am, because I had the footprints of the persons like Dr. Sheila Mani and Dr. Milinsha in our journey. So there are always, Dr. Gangadhar Sahu says that what the young generation should have, and the Dr. Sheila Mani, Dr. Milinsha, these are the people whom we have put their footprints and we have followed their footprints. So let me a little formal introduction of Dr. Sheila Mani. Please, Nisha, display the CV of Dr. Sheila Mani. Am I audible? Am I audible?
Yes, ma'am. Yes, ma'am.
So Dr. Sheila Mane has been, what we show, she has been known all over country as a PPH lady, a wonderful teacher, wonderful skill trainer, has been President ISOPARB Society, Bengaluru, Foxy Vice President. She has been elected for the ICOG Vice Chairperson and known as what he says, the teacher, DNB teacher, best teacher award for Dr. B.R. Ambedkar Medical College, best society committee chair, Dr. Mehrudara Hansotia, where we took the baton from Dr. Sheila Mane, and she is always there for us for every guidance and how the work should be organized. National Felicitator Adolescent Health WHO, and received MS Signature Award for phenomenal leadership in providing high quality EMOC services, which is still a dire need of country. So with this formal introduction and a very, very warm welcome for your gracious presence, Dr. Sheila, we will like to have your few views that what kept you moving throughout the country and throughout the years for PPH prevention, for teaching, reaching remote areas. What was this thing? What was that thing? What was that spark which kept you moving all over the country and all over the years? So we wish to hear you. With all the young generation is really keen to listen from you.
Yeah,
So,
thank you, Dr. Sadhna, for those kind words. And I really thank you for inviting me for this prestigious Yuva ISOPARB CME. Now, what kept me going is a very good question, which really makes me think. I think after finishing my chairperson post of Safe Motherhood Committee, where I concentrated on emergency obstetric care, and I did my first workshop with Professor B. Lynch. Okay, my first PPH workshop in Bangalore. And, you know, such a senior person and with so much of dedication, you know, he came all the way, and we had a hands-on workshop on blood loss assessment, which I had never seen earlier. And Dr. Mohanta was there with him. And the journey started in Cape Town, Figo, when I met him, and Dr. Bellat from Belgaum introduced me to him. So he came. So whatever uterus model I carry with me was actually I designed after seeing Dr. B. Lynch model only. And we had a hands-on demonstration. And those days, all of us, we know that I'm really happy to see all over the country now that people have really geared up in the management of postpartum hemorrhage. And I think all of you will agree. Okay, so now everybody knows the breast suture, the surgical management, and the stepwise medical management also. And I think it was all everybody's effort. I think I must acknowledge here even Dr. Sadhna, that repeatedly we have told, you know, like all of us, we know what needs to be done, but unless and until, you know, it is haunted or told every time. So then it becomes really, you know, everybody tries to do that. And I'm happy to share that now, after going around in the country, once I started that PPH, it really became my passion. When I looked at the maternal mortality, I knew that the PPH is still on the top. Okay. Right now also it is still on the top, but maybe hypertension in some certain states now it is the hypertension. And I think where I work also, I find now today is our problem is hypertension than postpartum hemorrhage, because most anemia is not so prevalent here. So that made me think those days that PPH I must concentrate, and I'm happy that that really helped the community. So I think, as we say, that we have Matru Rin, Pitru Rin, Guru Rin, and Samaj Rin also. So I think by God gave me this idea, and through this, if directly or indirectly, I was able to maybe some lives. So I think that is all God's wish. And I think one should not wait for the opportunity to come, you know. You can just think that whatever invitation you get on whatever you are trying to do is the best opportunity, and that automatically opens the vistas for you, and you will only not know. If I look back, I really don't know how I started and how I reached this. So definitely everybody's invitation, everybody was so interested, because everybody's sincere effort is to save the mother. And I think that really helped me. Even Figo also, when we did, we saw that not only India, but all over the world, the PPH is a problem. And Dr. Sadhana was also there with me in that workshop. The people are so eager to learn still because, they really need it, particularly the hands-on. And I think that is how, and I think our friends and my friends. And I really feel that that is my treasure today. Dr. Shashi is here. I really enjoyed recently when I did the PPH workshop in Hyderabad also with ISOPARB. So it's really nice, and the love and affection I get from everybody is tremendous, and that is my real treasure today. Okay. And as it is a Yuva ISOPARB, I would just like to tell the Yuva, as Dr. Gangadhar Sahu was telling, that the Yuva at our time and your time, I think you are more privileged as this is a digital world. You have every information at the tip of your finger, which we did not have. I still remember putting the ladder in the medical college library, taking out the journals to take the references for my thesis. I still remember, that was, now you people can do a lot. As from everywhere we are listening that data is so important. I think all the youngsters have to really make it a habit. They should have the data preserved, whatever they do. That will take India to a great height. Because if we have our own data with us, and if it is really, projected, and that will help us to do research that what our country wants, where we are lacking. Every state, I think every young people should do that. And excellence, you all should have, all of us have to achieve that. But excellence is not a one-time thing. And it's a habit, and let us chase excellence. Excellence is performing ordinary things extraordinarily well. And excellence is not a 1 week or a 1 year deal. It is a constant process. It is always the outcome of high intention, honest efforts, and intelligent execution. So let us all stick to this and see to it that we all try to achieve this excellence by doing the ordinary things excellently. Thank you very much once again for the invitation.
Thank you, Dr. Sheila. It was really touching, and it was something, a nostalgic memory which we have shared with a long journey in Foxy. And the young generation in tomorrow's time will be needing much more and more people like you, because actually it is money or it is something short thing which makes everybody passionate. No, it is something different from inner side which make you passionate and make a long journey in our profession. And India is still, what Dr. Gangadhar Sahu say, what you emphasize, we still need a lot of compassion and empathy. Few legal case, few negative things get so much of like a repercussion, and we tend to forget so many things which we get from our patient, and that much of gratitude. So thank you, Dr. Sheila. It was really great to have you. And with that, taking again the same thread to Dr. Milind Shah, who has been chairperson of Rural Obstetric Committee. Past years when Dr. Milind did a tremendous job in the COVID surgeries and the obstetrical care in COVID times. So it is the way how a person goes on moving. So let Nisha please share Dr. Milind Shah's CV. We welcome Dr. Milind Shah to grace the webinar as guest of honor. Nisha, please share the CV of Dr. Milind. So he has been president ISOPARB, past president IMA Solapur branch, founder president of IHRF, honorary treasurer FOPS, and the vice president of Foxy in 2011, and the senior second vice president is part, and has hold many positions. He has contributed for the journal OB-GYN and the past president Solapur Obstetric Society, and a professor and head department of OB-GYN, Gandhi North Edge Medical College, and national editor member for Foxy website, an ardent traveler. And we still remember his contribution to providing pulse oximeter in many rural areas, and suddenly in COVID time that pulse oximeter became something sort of the tool for the home management, and authored many books for few books we have also contributed. And Dr. Milind, what I say, from chairperson Rural Obstetrical Committee to the work in the COVID times and in the silent time when you did a lot of work for providing pulse oximeter to rural areas. So Milind, with all this journey, again, I will say to this question, from you are having a big practice in a small place as well as in a metro like a Bombay. How could you manage, just give message to our young generation that how you could do so much? And you are not old, you are quite very, very young. So Milind, your message. Stop sharing so we can listen to Milind.
Thank you very much, Dr. Sadhna, for all those words. Very true. Yes, we'll have to be always and always youth by heart, though the age definitely advances. But I think suppose we work, we keep on working, we can never become old as well. And that's what the zeal I'm seeing in the Gorakhpur ISOPARB. So that's why I'm so happy to meet you, Sadhna, Dr. Amrita, Dr. Babita, Dr. Radha, and Dr. Reena. Yes, we are doing wonderful work in the under the aegis of ISOPARB. ISOPARB is a group whereby we always and always try to communicate with not only our OBGYN friends, but also pediatrician, neonatologist, social scientist, whereby we can do something different as well. And that's why when I actually started working at a Asia Oceania level for the FAOPS, you all must be aware, as Fox is affiliated to FIGO, the ISOPARB is affiliated to FAOPS, that is Asia Oceania Federation of all parental societies, whereby we do a lot of work as far as the innovation is concerned. Let me give you one example of kangaroo mother care. Such a wonderful intervention and the practice which we can adopt in our day-to-day practice makes a wonder, especially for all those low birth weight babies, premature babies, but I would say even term babies. And that's why when we started discussing it, we got very good response from all these countries, and we started making more and more awareness activities as well. We have advanced a lot in the genetics also, whereby we need to percolate that particular knowledge to all our neighbor countries as well as to all our rural setups as well. And that's why I always try to go to even very, very small places, small rural areas, to see that those people adopt the good practices. And one of that, which is very important as far as the obstetric is concerned, surgical safety checklist and the hypoxia management. Because we know in rural centers, quite often there is a scarcity of certain gadgets, but also scarcity of the certain protocols which need to be observed. And that's why I remember Dr. Gangadhar must be knowing, when I went to Burla Sambalpur, we got a wonderful response, not only from all doctors, but media, general public, the social workers, all of them, they came together because of the love of them towards Dr. Gangadhar Sahu, but also gave me an opportunity to speak with them. And I realized, yes, now it's the time that we should do something for them as well. With the same intention, Sadhna, we started this activity, and luckily my wife, who's an anesthesiologist and also ISOPARB member, she supported me for this particular activity. Now, when we were doing all these activities for the rural India, we also realized urban slums are again the people who are not getting adequate attention. To my surprise, in Mumbai itself, I realized that 22 BMC maternity homes were not having pulse oximeters. And they were doing deliveries, they were doing cesarean sections, they were doing tubectomies. And then I approached the authorities and we conducted a separate workshop for them for surgical safety checklist and hypoxia management. And we donated those pulse oximeter. And throughout this journey, the Lifebox Foundation supported a lot for this wonderful activity. I'm very sure in coming days, the things will definitely change a lot. Recently, when I traveled to Punta Cana, West Indies, I realized that COVID has changed a lot. COVID made a lot of things really miserable as far as the work as well as the economy is concerned. But again, we need to come forward. And that was the intention. Though I was not very suitable to manage COVID positive cases, I entered doing all those cases as well. because all those unfortunate pregnant women were ailing, were unable to get the services because a lot of burden on the government sector. And we realized, suppose we adhere to this safety checklist, which we design as well as a COVID safety checklist, we realize we don't contract the disease. Suppose we take due care, we use those protective gears. To my surprise, I delivered 25 actually COVID positive mothers. But fortunately, and with the God's grace, didn't got COVID infection at all in this particular journey. And that gave a sort of, the more encouragement to all those Yuvas, because they were thinking that no, we will sit at home and only government actually they will look after all these positive cases. I said, no, in government as well, who is going to nurture the services? Our own kids, our daughters, our sons are going to give the services, because naturally the age was a limiting factor for the elderly faculty to enter in the government setup as well. So why not come forward to at least support our own kids and give them services in your limit without doing unnecessary venture, but adequate precautions will definitely make a major change as well. And I'm very sure that gave a lot of actually love and affection from all those youngsters who were very happy, and they were very happy to understand about the safety checklist. The Royal College as well took the cognizance of this particular work, and we conducted with their help a very good actually safety checklist in the COVID scenario workshop for all the theaters across the various nations. And that was a wonderful actually satisfaction we received. I'm very sure in this particular webinar, whatever we are going to discuss about the circulage, about fetal reduction, and very important for the premature rupture of membranes will be of great benefit, Sadhana, because premature rupture of membranes, when we wrote actually for the AOFOG this booklet, we realized that yes, a lot of things can be done to prevent, to treat, to manage, as well as the post-management if at all the baby delivers. And that is what the ISOPARB also looks forward, because ISOPARB is basically a chapter who looks after the perinatology. And I'm very sure that today's discussion is going to be a great benefit. And I must congratulate you entire actually group of ISOPARB Gorakhpur chapter for initiating this Yuva, actually the concept. And let us have a good friendship with our young friends to understand newer things in the clinical practice. Thank you very much for this honor and the invitation, Sadhana. Thank you very much.
Thank you. Thank you. It was really a great sharing of, like, it is a revisit our past with Dr. Sheila and Dr. Milind. And I think the greatest asset of our life, of Dr. Sheila says, it is saving life. One of the greatest asset is to have the association of the people like Dr. Sahu, Dr. Sheila, and Dr. Milind, and that is the ultimate aim in itself. So thank you, Dr. Sheila and Dr. Milind, and Babita, you can continue with the scientific session now.
Yes, ma'am, we have received some really wonderful messages today. Some talking about the ABCD approach towards life, and Sheila Mane ma'am talking about excellence is a constant process. And as we have our duties towards our parents, our children, and our teachers, we also owe our duty to the society. And Dr. Milind Shah actually going ahead to the rural areas and really helping them out, providing pulse oximeters. So we have such wonderful seniors with us. It is a lovely message to the Yuva, not only about education, but about how to live life. So now carrying forward our scientific session, we move towards our first session, where we'll have a wonderful talk to be delivered by none other than a very active member of Gorakpur Obs-Gynae Gynae Society. She is President GOGS, Secretary ISOPARB of Guru and Secretary of Menopause Society Gorakhpur chapter, Dr. Amrita Sarkari Jaipuriyar. She will be talking on fetal reduction, selection, techniques and outcome. And for this wonderful session, I would like to invite our esteemed chairpersons, Dr. Neelam Ori ma'am. Kindly flash a CV. Nisha. Dr. Neelam Ori ma'am is Medical Director, New Life Hospital and Advanced Fertility Center, Varanasi. Ma'am is chairperson ISAR UP and secretary UP IS 2122, secretary of Varanasi Menopause Society and past president DOGS. She has several publications in national journals and chapters written for books, recipient of several awards, organized many national conferences on infertility, fetal medicine, and endoscopy workshops, and recipient of Shane Kashi and Kashi Ratna Awards. Our next esteemed warm welcome to you, ma'am.
Thank you, Dr.
Now,
Babita.
our next esteemed chairperson is Dr. Shashikala Kula. Ma'am is consultant gynecologist and obstetrician birthright by Rainbow Hospital, Banjara Hills. She has past Joint Secretary, Vice President of OGSH, past Secretary, Vice President, President, ISOPARB Hyderabad Chapter, past South Zone Coordinator for ISOPARB. Currently, ma'am is Vice President, ISOPARB. Her field of interest being endoscopic surgery, vaginal surgery, and high-risk obstetrics. She has contributed chapters for postgraduates in obs and gynae books and is trained in robotic surgery at Atlanta. A very warm welcome to you, ma'am. And our next chairperson being Dr. Surita Karim. Ma'am is director of Star Hospital and IVF Center. She has served as president of Gorakpur Obs and Gynae from 2016 to 18 and served as secretary Gorakpur Obs and Gynae Society, organized the first live workshop on NDVH at Star Hospital and first live workshop on laparoscopy and hysteroscopy at UPCOG Gorakhpur. Ma'am is trained in ART and IVF and has started Safal, the first successful IVF center at Gorakhpur, trained in laparoscopy and hysteroscopy and organized several hands-on workshop on IUI and endoscopy training. A very warm welcome to you, ma'am. And I would request Dr. Surita Karim, ma'am, to introduce our speaker of this session, Dr. Amrita Sarkari Jaipuriyar. Warm welcome to Surita, ma'am. Ma'am, are you there? Ma'am had joined. I'd seen her.
Yes, I am very much here, Babita.
Okay, ma'am. Okay, ma'am.
Yeah, actually, I'm traveling, so I told Sadhna I'll be joining online. And anyways, first of all, a very big congratulations to the whole team of ISOPARB, and a special warm welcome to Professor Sheila Mane, Professor Sahu, and Dr. Milin, who is a very good friend. And I would love to introduce our speaker for this session, Dr. Amrita Sarkari. So can we have her CV on the board? Babita, can you ask Nisha to share the CV?
Please display it, ma'am.
Yeah. Yeah.
Yes.
Thank you. So as we can see, Dr. Amrita Sarkari, of course, needs no introduction to Gorakhpur Society, and I think now many societies also know her. So she has been she's been the president. She's currently the president of our society, and she's been the past secretary as well as the treasurer of Gorakhpur Menopause Society and secretary ISOPARB Gorakhpur chapter. She has been the organizing secretary in the workshop in maternal mortality in North Zone Yuva Congress, Yuva Foxy in 2010. And she's the editor of all the souvenirs of the above conferences. And she is a very dynamic personality. She has organized hysteroscopy workshops in 2017 and presented a paper in AICOG. Figo.
Namaste, ma'am. Bas rehne dijiye. Thank you.
So I think everybody can see her.
You
CV.
don't
She's
know.
a
Need to.
very active member of the PCOS society as well. So gives me a good opportunity to know your achievements, Amrita, and it's always a proud privilege to share them with as well. And the topic of the day is a very interesting topic. So, and I also welcome Dr. Neela Mori, my immediate senior from BRD Medical College, and kindly go ahead and deliver your talk, Amrita.
Thank you, ma'am. Thank you for the lovely words. And we are just inspired by all the seniors and everybody here. My respects and regards to Sahu sir, Dr. Sheila Mane ma'am and Milind sir, and all my love to Sadhna ma'am and best wishes for her ventures. So I'm really honored and glad that I have been invited to speak on this topic. Is my slide seen?
Yes, yes.
Okay. So the topic allotted to me is fetal reduction, selection, technique, and outcome. Here we are not like them. We are not like hen and goats. So the incidence of high order multiple pregnancies has increased in the recent decades following the rise of assisted reproductive techniques. And this results in complications for the pregnancy, such as miscarriage, extreme preterm delivery, stillbirth, and preeclampsia. These have short and long-term implications on the physical and mental health of the children, as well as the quality of life for the families. We all know that stock doesn't bring the babies, and the poor girl lady has to bear all this. And besides the body image she is conscious about and the load she is carrying, there are so many complications in pregnancy, right from miscarriage, hyperemesis, anemia, preeclampsia, preterm labor, and the distress she has like palpitation, dyspnea, varicosities, hemorrhoids, and obstructive uropathy. During labor, there can be premature rupture of membranes, cord prolapse, so many complications, and she can also have postpartum hemorrhage. And in the puerperium, subinvolution, infection, and lactation failure. Fetal complications are many, and we all know that they are more with the monochorionic multiple pregnancies, like spontaneous abortion, fetal demise, vanishing twin before 10 weeks, fetus preparations, compresses when it occurs in second trimester, and complications which occur in second twin, the living twin. They are neurological, renal lesion, anemia, DIC, and hypertension and death. Fetus can be low birth weight, premature delivery is very common, growth restrictions are seen, and there is discordance in the twins or triplets. When there is difference of more than 25% in weight, more than 5% in head circumference, and more than 20 millimeters in abdominal circumference, we call the babies as discordant. And there can be abnormal Doppler waveforms. The causes being unequal placental masses, lower segment implantation, genetic differences, twin-to-twin transfer syndrome, and congenital anomaly in one or both the fetuses. The anomalies can be like conjoined twins, neural tubal defect, anencephaly, etc. And in twin-to-twin transfusion syndrome, the cause is usually AV communication in placenta, and blood from one twin goes to the other. One becomes the donor, which suffers from IUGR and oligoamnios, and the recipient has overload, hydramnios, CHF, and IUD. TRAP is one of the complications of twins, twin reversed arterial perfusion syndrome, or acardiac twin, when there is absent heart in one fetus with arterio-arterial communication in placenta, and the donor twin also dies. Cord entanglement is very common, compression is common, asphyxia, stillbirth. Asphyxia and stillbirth can occur antepartum and intrapartum also. Here we can see the complications which occur in monochorionic pregnancies. And there are certain complications which are specific to monochorionic twins. They are the twin-to-twin transfusion, selective fetal growth restriction, and twin anemia polycythemia sequence. The story doesn't end here. We can see triplets are born, but you can see the problems with so many children or children of the same age. Social and financial implications can also adversely influence the families of multiples, with higher financial demands, stress and depression of the parents, leading to higher divorce rates and poor family relationships. So today we are talking about this, and those were the reasons why we were talking about this. Multifetal pregnancy reduction and selective termination. Although several different terms are often used, the current consensus on terminology is termination of an abnormal fetus should be described as selective termination, whereas termination of one or more normal embryo in a high order multifetal pregnancy should be termed multifetal pregnancy reduction. So here is a brief description of the selective fetal reduction. It refers to a procedure in which one or more specific fetuses or a multifetal gestation are terminated due to a known or suspected fetal abnormality, including a chromosomal, structural, genetic, or growth abnormality, which has been identified by ultrasound examination or by definitive fetal diagnostic testing after amniocentesis or chorion villus sampling. Here's just a small comparison of medical indications, context, impacts on parents, and ethical issues between selective termination and fetal reduction. So number of fetuses are usually two in selective termination, and in fetal reduction, usually more than two. So I will not go into much of the details, but here we can see that fetus diagnosed with serious illness or malformation is in selective termination. And for fetal reduction, we do that for reducing the fetal mortality or reducing the maternal morbidity, and also sometimes for socioeconomic conditions. Usually in selective termination, the pregnancy is spontaneous, but in fetal reduction, it is medically induced. There are certain ethical issues also, and therefore we proceed to the further they saying that how are we going to do the selective termination or multifetal reduction. It should be only provided with a tertiary level fetal medicine service, and such services should be equipped with specialist ultrasound diagnosis, counseling by a specialist in fetal medicine, clinical genetics, and neonatology. Psychological support by specialists, midwives, and bereavement counselors, invasive prenatal diagnosis, and expertise in complex fetal intervention with an adequate annual case workload to maintain competence, regular audit of outcomes, and multidisciplinary care review and oversight. So these are the pre-procedural considerations. Local regulations are very, very important and should be considered. It is important to know the law in the country in which the selective termination is performed and to be aware of any special legal considerations, such as a waiting period between signing the consent form and undergoing the procedure and gestational age constraints. Fetal assessment is the most important thing to be done, and the first step is to correctly identify the fetus to be terminated. Previously diagnosed fetal abnormalities, particularly genetic disorders in which the fetus may appear sonographically normal, are not always obvious at the time of selective termination. Correct identification of the affected fetus can be made by ultrasound detection of a structural abnormality if there is present, or by the gender if discordant, or by previously documented fetal gestational sac or placental position. Fetal assessment should be done if there is any doubt as to the correct identification of the affected fetus at the time of termination. Rapid determination of fetal karyotype by fluorescent in situ hybridization FISH technique, which is called, can be performed before the procedure, assuming the abnormality is detected by FISH. Results of FISH are usually available within 48 hours. And although the fetuses will move around, the relationship of such sac, of each sac to the other sacs, and the position or appearance of the placenta will not change much in these 48 hours. Before doing the procedure, we should also consider the chorioamnionicity. As with multifetal reduction, pregnancy reduction, accurate determination of chorionicity is crucial before performing selective termination, as termination techniques are different for dichorionic versus monochorionic pairs. So the first step is the number of fetuses and their chorionicity should be documented before 14 weeks of gestation. Different sonographic signs may be used to evaluate chorionicity, that is, the number of placental masses, sex of the fetuses, and characteristics of the intertwined membrane. Characteristic of the membrane is a very useful and valuable tool. The takeoff of the membrane from the placental surface shows the typical lambda appearance in dichorionic pregnancy and the typical T appearance in the monochorionic ones. So chorionicity refers to the type of placentation and does not reflect the zygosity. Whereas dizygotic twins are always dichorionic, monozygotic twins may be monochorionic or dichorionic depending on when the zygote divides. The corner theory clarifies that if the split of zygote occurs between the first 3 days following the fertilization, dichorionic, diamniotic twins develop. This occurs in 29% of cases. When the split occurs 4 to 7 days after fertilization, a monochorionic diamniotic twin pregnancy develops, and it occurs in 70% of the cases. In 1% of cases, the split occurs later, between 8 and 12 days, resulting in monochorionic monoamniotic twins. And when a partial splitting of the zygote occurs between 13 and 16 days following fertilization, conjoined twins develop. This is an extremely rare condition occurring in up to 2 lakh births. So here we can see the first trimester ultrasound. Here we can see a dichorionic twin pregnancy at 5 weeks, 3 days, and 2 round sonolucent sacs with a brightly echogenic rim. They are clearly visible in the thick decidua. Here at 6 post-menstrual week, a single chorionic sac is seen containing 2 yolk sacs. The diagnosis of the monochorionic twin pregnancy can be done. It is not possible yet to diagnose the amnionicity. Here we can see a monochorionic diamniotic twin pregnancy at 8 post-menstrual weeks. The 2 amnions appear as thin echogenic membranes. The arrows can be seen there. They are close to the 2 embryos inside the coelomic cavity. This picture shows the twin peak sign. Arrow is there. In a dichorionic twin pregnancy, the lambda sign can be seen. And below the figure number 5, the T sign in a monochorionic twin pregnancy in the first trimester. Assessment should include detailed documentation for each fetus to enable labeling. We should label the fetuses and label their position, size, chorionicity, placental location, and any anatomical feature that may help their correct identification, such as major anatomic abnormality and markers of aneuploidy. Determination of chorionicity is essential not only to help estimate the prognosis, but also to determine the method of the fetal reduction or selective termination. Fetuses with a monochorionic placenta share a common circulation, and the demise of one fetus with or without intervention may lead to hypoperfusion injury in the remaining fetus or fetuses, with resulting death or cerebral injury. Coming to the procedures and techniques, several methods for selective fetal reduction have been described, which are chosen based upon chorionicity, risk profile, and expertise of the practitioner. And the timing of reduction impacts the rates of miscarriage and preterm birth. Earlier reduction, particularly in the first trimester, can result in a smaller rate of fetal loss. Parents can be offered late reductions in the third trimester if the diagnosis of single fetal anomaly was made in the second trimester. This reduces the risk to the remaining fetus to preterm delivery only. Late reductions, however, may not be permitted by the law in some countries and could be more distressing to the parents. Therefore, careful and sensitive counseling should be taken to balance all the risks over benefits. In the first trimester, selective termination. When selective termination is performed for a fetal abnormality during the first trimester, great care should be taken throughout the procedure to correctly identify the affected embryo. In particular, When the chorion villus sampling confirms a chromosomal or genetic abnormality, care should be taken to minimize the time interval between the diagnostic CVS and subsequent selective termination, and the same operator should be performing both the procedures. The procedure is intrathoracic potassium chloride. Chorionicity should be determined using the ultrasound by 13 plus 6 weeks gestation. In cases of chorionic triamniotic triplets or dichorionic triamniotic triplets, where the decision has been made to reduce the dichorionic triplet or to reduce both the monochorionic fetuses, intrathoracic potassium chloride is the preferred method. In monochorionic pregnancies, that is reduction of one of the monochorionic fetuses to dichorionic triamniotic triplet, or in monochorionic twins or triplets, KCl injection could result in the death or neurological impairment of other fetus sharing the placenta. Why? Why? This occurs due to its leakage, due to the leakage of KCl through the placental vascular anastomosis, and to acute hypotension and hypoxia, as blood is shunted through the placental vasculature of the dying twin. So selective reduction in monochorionic pregnancies should be performed using bipolar cord coagulation, radiofrequency ablation, or intrafetal laser ablation. So when we select a procedure for fetus with independent chorionicity, current method of choice for fetus with independent chorionicity is direct intracardiac injection or KCl. This is performed as an outpatient procedure under local anesthesia. A percutaneous feticide technique is used for the intracardiac injection of a chemical agent to induce fetal asystole. A 20 gauge or 22 gauge amniocentesis needle is advanced into the amniotic cavity and then into the fetal heart, through which 0.5 to 2 ml of 15% KCl is administered until fetal asystole is confirmed. Role of prophylactic antibiotic cover has not been investigated in trials, but an intravenous single dose of broad spectrum antibiotic is sometimes used. For third trimester selective termination in independent chorionicity, if a fetal abnormality becomes apparent in dichorionic twins or higher order multifetal pregnancies after 16 weeks of gestation, then a safe alternative to mid-trimester selective termination is to administer intracardiac KCl feticide at 32 weeks of gestation. Although there is a high risk of preterm birth within 3 weeks of this procedure, such timing carries no risk of miscarriage, and major disability is much less likely. At 32 weeks of gestation, usually after prophylactic steroids have been used, the procedure is performed with aseptic technique by administering an intracardiac injection, and the procedure is same as which is done in the first trimester of pregnancy. Terminating the wrong fetus is a possibility, so the operating practitioner should take great care to identify differentiating features such as placental position, fetal sex, and readily visible anatomical abnormality. Intravascular administration of KCl via chordocentesis should be avoided. Coming to the monochorionic fetuses, when selective termination is performed on a fetus within a monochorionic pregnancy, chemical feticide should be avoided. The options are radiofrequency ablation, bipolar diathermy cord coagulation, intrafetal laser ablation, and suture ligation. In radiofrequency ablation, it can be done between 15 and 27 weeks of gestation. Ultrasonic guidance is used, and a 17 gauge radiofrequency ablation needle is inserted percutaneously at the level of intrafetal portion of the umbilical cord. Radiofrequency energy is applied at the electrodes, which are called tins, situated on the tip of a radiofrequency ablation needle, until an average temperature of 110 degrees centigrade is achieved in all the 3 tins for 3 minutes. 2 or 3 such cycles may be applied until cessation of blood flow is demonstrated by color Doppler of the umbilical cord. Coming to the bipolar diathermy cord coagulation, it is done after giving a small skin incision and using ultrasound guidance and intraamniotic 2.7 millimeter or 3.3 millimeter port is placed under local anesthesia. Bipolar diathermy forceps are introduced to grasp a free loop of the umbilical cord. The cord is fully coagulated along several points using short bursts of 30 to 50 watt bipolar electrocautery for up to 60 seconds per burst. The procedure is complete when color Doppler shows cessation of cord blood flow and fetal asystole. Ideally, umbilical cord thickness should be less than 12 millimeter. The procedure is usually performed at between 18 and 27 weeks of gestation because there is an increased risk of co-twin death at gestations earlier than 18 weeks. Intrafetal laser ablation. For this, an 18 gauge needle is inserted into the fetal abdomen adjacent to the pelvic vessels, and then a 400 LM laser fiber is advanced 1 to 2 millimeter beyond the tip of the needle. Laser coagulation is performed using ND-YAG laser at 40 watt until cessation of blood flow in the iliac arteries and umbilical vein is demonstrated. Fetal asystole is confirmed around 60 minutes later. The advantage of intrafetal ablation is that it can be used with a free loop of cord when a free loop of cord is not easily accessible, such as in a trap sequence. Even suture ligation can be done. A single port is inserted in the amniotic cavity and the looped end of the monofilament suture is introduced using 2 millimeter forceps and placed under the cord. And in this, the extracorporeal knot tying is applied using an endoloop pushing device, followed by confirmation of cessation of cord flow using color Doppler. There are certain newer developments also. Microwave ablation. It has been tried on a smaller number of pregnancies where a coaxial antenna emitting microwave energies is inserted into the fetal abdomen and the energy is applied for 3 minutes. It has a potential advantage over laser ablation in that the coagulation effect is seen immediately. A larger area can be covered and a minimal heat sink effect means less ablation zone distortion. So this is a newer technique, not yet in practice, but we will definitely find an answer after a few years. High intensity focused ultrasound aims to bring a non-invasive technique into fetal therapy, and a transducer is placed on woman's abdomen and targeted ultrasound energy is transmitted through the abdominal wall and the uterus to cause vessel occlusion. Currently, this has been limited to animal studies only and in small numbers of trap sequence and twin-to-twin transfer syndrome cases. So there are a few studies when we come down to the the views of many authors, and many studies have been, this is one of the author, Dr. Beke Louis and Professor Asma Khalil, and they have in their studies found that when the procedures are done of the selective reduction in dichorionic triamniotic triplets, the miscarriage rate was less, but preterm birth rate was high. So these procedures of reduction and multifetal reduction can reduce the miscarriage rate. Although we expect preterm birth, but these babies can be managed in an ICU, and also before the delivery, the corticosteroid cover can be given.
Amrita ji, we have 3 minutes for this talk.
Okay. So all the studies show that the preterm birth rates are higher and the fetal loss is less. Again, a study which shows the same results, and they have studied in dichorionic diamniotic twins and also in the triplets. So there are certain ethics which should be followed, And the decision making required by the expectant parents is extremely difficult given the risk of miscarriage associated with the procedure, balanced against the benefit of risk reduction for preterm births and adverse maternal outcomes. So everything should be discussed with the parents and the risk over benefit should be told. Recommendations are very important. On the basis of the principles outlined in this committee opinion, the American College of Obstetricians and Gynecologists make the following recommendation. Fertility treatments have contributed significantly to the increase in multifetal pregnancies. So primary prevention strategies to limit multifetal pregnancies, especially high-order multifetal pregnancies, can help to minimize the need of multifetal pregnancy reduction and should be practiced by all physicians who treat women for infertility. Obstetrician gynecologists should be aware that the multifetal pregnancies increase the maternal and fetal perinatal morbidity and mortality. So while counseling, the counseling should be non-directive and offered to all women with high order multiple fetal pregnancies where termination is suggested. And the counseling should be made where to a center, a high center where neonatologist, genetic expert, mental health professional, and a good NICU and a great gynecologist is available. So to conclude, selective fetal reduction is a complex area where both risks and benefits to the pregnancy are well documented. Clinicians must be familiar with the facts involved in this area and provide the counseling in a sensitive, non-judgmental manner. Referral to a fetal medicine center should be made, whether it is to carry out the procedure by a specialist or to provide close monitoring of the complex high-order pregnancy. The patient's decision must always be respected and support provided where needed. The best step is primary prevention. So a mother says to her daughter, "I'm always with you. Be brave, have courage, and love life." Thank you.
Thank you, Amrita. Very comprehensive talk, and you nicely covered all the aspects of fetal reduction. And we know now it is a very widely accepted procedure, and this infertility treatment has contributed a lot for the multifetal pregnancy. Here I wanted to add one thing, that earlier maybe 6-7 years back, we were doing fetal reduction in earlier gestation, like 9 to 11 weeks. Now it has shifted to 11 to 14 weeks only when we, because sometimes fetus undergoes a spontaneous demise or missed abortion, and we do all the assessment of the fetus fetal reduction. And earlier we were doing it transvaginally when the fetus established that So yeah, the only thing is that with so much prevalence of fetal pregnancy, now we are doing single childbirth or double childbirth only. So we need but yet sometimes we need it. And as you said, that 32 weeks not allowed, we know, in our country. After 20 weeks, we cannot go beyond that. So really nice. And I remember Dr. Sutra, about 10 years back, I called her to my reduction of early.
Yes, I remember that too, Nilamji.
Yeah.
But now thankfully,
yeah, now we have
1 to 2 fetal transfers. So yeah.
Now we
the chances of multiple pregnancies has reduced. Yes.
Earlier, now it is not. Thank you, Amrita. Very nice talk.
Thank you, ma'am. Thank
you, Amrita.
Thank you, Dr. Amrita. That was a wonderful presentation. Because I remember speaking to Dr. Paul Devroy of Belgium almost 15 years ago. He was a great proponent of single embryo transfer. He says always you should do single embryo transfer. I think that is the key, as you mentioned, is the last final word in your presentation is primary prevention. So the woman should not be subjected to go through all these stress because of our ART procedures. And also whenever you're doing IUI also, when the woman has got multiple dominant follicles, maybe you should convert it into an IVF, take the embryos and then freeze and then do it, because 3-4 dominant follicles, and it could end up with a triplet pregnancy. And again, the patient has to go through all these things. So primary counseling the patient about the dangers and the problems and what all they need to go through, if we continue with the procedure at that point, would go a long way. And of course, if it happens, we have to consult and go for the fetal reduction in the most ideal and the safe way possible. Thank you very much for a wonderful presentation.
Thank you, ma'am. Thank you so much.
Suvita, ma'am, you want to give any inputs? Ma'am, please.
No, I'm okay. I'm absolutely agree that primary prevention should be the goal. But I am very glad that now we have newer modalities as well, like laser and this ablation, which Amrita has mentioned in her talk. It's also something new. Is doing a wonderful work on this. So congratulations again.
Thank you, ma'am.
Thank you so much to our speaker for such an elaborative talk, and to all our chairpersons for their fruitful inputs. Now, ending a session, first session, I hand over the session to my co-coordinator, Dr. Ritu Srivastava. A warm welcome to you, Dr. Ritu.
Thank you, Dr. Babita. A very good evening to everyone. After the brilliant session 1, let's quickly move on to the second talk, that is on cervical circulage. And to grace the occasion, the experts are Dr. Tulika Jha. She is Associate Professor and HOD of Gynae Rampurhat Government Medical College, West Bengal. She is member of High-Level Task Force for Maternal Health Checkups of Government of West Bengal. She is a trainer in many courses, and she is a Secretary ISOPARB 2021-23, Kolkata chapter, and she has many publications and has authored various chapters. We welcome you, ma'am. Then Dr. Ranjana Khanna, ma'am. Madam is Senior Consultant and Director, Ranjana Hospital, Prayagraj. She has adorned many positions as National Vice President, POXI, Founder President, Prayagraj Chapter of ISOPARB, 2021-23, ICOG Governing Council member. She has been organizing secretary of plenty of conferences. She has won many national awards like POXI, Smriti Malen Award, Dr. DK Tang Trophy, and has authored many articles and chapters. We welcome you, Dr. Ranjana Gupta Khanna, ma'am. Then Dr. Madhubala Sharma, ma'am. Madam is Vice President, ISOPARB Gorakpur chapter. She is Vice President of Menopause Society, and she is past President of GOGS. Above all, she is a very witty, lively, and a lovely human being. I welcome all of you, ma'am. Now I welcome Dr. Hema Bindu Annam Raju, who will be speaking on cervical circulage. And to introduce her, I would invite Dr. Tulika.
Thank you. Thank you so much, Dr. Srivastava. It's my pleasure and to be here. And first of all, I would like to thank everybody from the ISOPARB Gorakhpur chapter to invite me here as a faculty, as an expert. It's always good to be among all of you, and especially since we met in Varanasi. So after that, everybody seems like a close friend. So thank you very much. So moving on with the academic session, it's my pleasure to invite Dr. Hema Bindu Annam Raju. She's a consultant obstetrician, gynecologist, and laparoscopic surgeon at Rainbow Hospital, Hyderabad. She has more than 15 years experience and in this subject and several international publications and presentations. She is a highly successful college tutor and received clinical excellence awards in the NHS UK. She also received Going the Extra Mile award in the NHS UK, and we are all waiting to hear her speak on cervical circulage. So the dais is yours, Hema Bindu, and over to you for your talk.
Good evening, everyone, and thank you very much for your wonderful words. I just want to say that this is my absolutely first ISOPARB conference, and I feel very, very privileged to be amongst so many of you who are so senior, so experienced, and so inspiring. And thank you very much for giving me the opportunity to be able to speak today. So let me just start my question. So I'm going to talk about cervical cerclage. So as we all know, a cerclage is basically, it includes various surgical procedures, which can be a synthetic suture or a tape, which is used to reinforce the cervix. And we can see here that this is an open cervix, and this is where we put in a cerclage to try and improve the strength of the cervix to improve the pregnancy outcomes. The indication for a cerclage would be if there is cervical insufficiency based on the patient's past history, or on a transvaginal scan if we see premature shortening of the cervix. We can also sometimes do it if on speculum or digital examination we see a prematurely effaced or a dilatation. Contraindications for the cerclage would be if there are any fetal anomalies which are incompatible with life, obviously if there is fetal demise, if there is an intrauterine infection, if there is a preterm prelabor rupture of membranes, active preterm labor, or active uterine bleeding. Prolapsing fetal membranes through the external os is not an absolute contraindication. It is considered a relative contraindication. And multiple pregnancy is not a contraindication. So when do we do the cerclage? As we know, we can do it as an elective procedure or as an emergency procedure. Elective procedure is generally based on the woman's history. So if the history of the woman indicates that she's had previous multiple mid-trimester losses or preterm deliveries under 34 weeks, then we could do it as a planned procedure between 12 to 14 weeks. We can also do an emergency cerclage or a rescue cerclage, which is generally because the ultrasound scan shows a shortened cervix. And this can be considered up to 27 plus 6. So we'll talk a little bit more about the gestation for cerclage. Generally, cerclage is not done less than 12 weeks because we would wait until the first trimester aneuploidy screening is complete. Once the first trimester screening is done and the NT scan is done and we know that there are no major anomalies which are not compatible with life, then we would consider doing the cerclage. So between 12 to 24 weeks is when cerclage is generally done. Beyond 24 weeks, cerclage can be considered. Up to between 24 to 28 weeks, this is a period of very high neonatal morbidity and mortality. So it's very important that we individualize the cases because we need to discuss with the patients of everything about the risk and the benefit about this procedure and what the outcome may mean for the baby. Beyond 28 weeks, cerclage is generally not done. When we say a history indicated cerclage, we're talking about women who've had previous mid-trimester losses or preterm deliveries under 34 weeks, or preterm prelabor rupture of membranes under 34 weeks. It's interesting to note that the Royal College of Obs and Gynae UK says that in a woman with no additional risk factors for preterm delivery, we cannot offer a history indicated cerclage unless she's had at least 3 pregnancy losses or preterm deliveries. The American College of Obs and Gynae says that we can offer if the woman has had at least 2 preterm deliveries or mid-trimester losses. What they're saying is do not offer a history indicated cerclage, but you can offer ultrasound monitoring of the cervical length. So ultrasound monitoring of the cervical length can be done, like we just said, in any woman who's had a previous mid-trimester loss or a spontaneous preterm delivery under 34 weeks. We can also do it for a previous preterm prelabor rupture of membranes under 34 weeks. Other indications for doing ultrasound monitoring would be if the woman has had a previous use of a cerclage, if there are known uterine anomalies like a bicoronate uterus, if the woman has had a previous cervical cone biopsy, and 2 or more LETS procedures, which is the large loop excision of the transition zone. If the woman has had more than 2 late surgical termination of pregnancies, more than 12 weeks, that is also an indication to monitor cervical length. If there is a history of radical trachelectomy, this is a procedure which involves removal of the cervix for cervical cancer. It's a fertility sparing procedure. And in this procedure, generally, the cerclage is inserted at the same time as the in multiple pregnancy, we can do ultrasound monitoring of the cervical. So this is what we see on the ultrasound scan. We can see the internal os here and the external os here and of the cervix, and the distance between these two. During cervical length measurement, if we find that the cervical length is less than 25 millimeters before 24 weeks, that is an indication for a cerclage. Again, if we see funneling as well, that would be an indication for a cerclage. This picture shows that the cervical length has become quite short and there is evidence of funneling. So if we find this on a transvaginal ultrasound, that would be an indication for a cerclage. So when we do an emergency cerclage or a rescue cerclage, it's very important that we discuss with the parents about the process, the risks, and the benefits, and we take their views into consideration. Studies have shown that after a rescue cerclage, the average prolongation of pregnancy is about 34 days. So it can be somewhere between 3 to 5 weeks, basically. This is in comparison to just expectant management and bed rest. So if we diagnose cervical shortening and funneling, say, in a woman at 20 weeks, we need to discuss this with the parents and tell them that, yes, we can do a rescue cerclage. Yes, we will be prolonging the pregnancy, but we are probably going to end up delivering this baby around 24 to 28 weeks, which is a stage where there will be high neonatal morbidity. And we might be saving a baby that might otherwise die, but will end up with severe morbidity. So it's very important to discuss this with the parents so that they understand what they're actually going for. And if they are agreeing to go for it, then yes, we go ahead with the rescue cerclage. The other consideration is if the cervix is dilated more than 4 centimeters and the membranes have actually prolapsed beyond the external os, then there is a very high rate of cerclage failure. If the cervix is not 4 centimeters dilated and the membranes are coming out of the external os, then we could consider doing a cerclage. And there are various methods that can be undertaken so that these membranes go back in. Simple thing would be just a head down tilt, and with gravity, the membranes should be able to go back in. If that doesn't help, we can also use like a little Foley's catheter, which we can use to just push the membranes back up, inflate the balloon, put the cerclage, and then deflate the balloon and remove the catheter. In some centers, amniocentesis is also suggested to exclude infection because we know that infection is one of the commonest causes for preterm labor. So once the cervix is dilating and the membranes are prolapsing out, we have to exclude infection. In order to exclude infection, we could consider doing an amniocentesis because that does not increase the risk of preterm labor. And once from amnio, we diagnose that there is no evidence of ongoing acute infection, then we could consider doing a cerclage. Other considerations is amnio reduction should not be routinely done before emergency cerclage. We know that infection could play a role in preterm labor, so screening for infection is necessary. But again, considering a routine vaginal swab may not be necessary. Once the cerclage is done, some consultants do a fetal fibronectin test as a follow-up every 1 to 2 weeks. A negative fetal fibronectin test provides reassurance, and that is the main reason why it's done, but it's again not routinely recommended. Another method of follow-up would be serial cervical length measurements, which is again not routinely recommended, but may be useful if the cerclage was a rescue cerclage. Moving on to the actual procedure. Before we do the procedure of the cerclage, it's very important we confirm the fetal viability and the heartbeat, cardiac activity. We must exclude infection. We would be giving antibiotic cover for the procedure, and we would also be considering progesterone supplementation with the procedure. The technical goal of the cerclage, like we discussed, is to reinforce the cervix at the level of the internal os. And we know that the longer the cervical length, generally the longer the duration of the pregnancy. There are 2 ways we can do a cerclage, which can be transvaginal or transabdominal. A transvaginal cerclage can be done with 2 methods, either McDonald's or Schirotker's. McDonald's cerclage is simplest of all the 3 procedures. It is easy to perform because it does not involve dissection of the bladder or the bowel. We grab hold of the cervix, generally with a sponge holding forceps. We apply traction for the cervix and then start at around 12 o'clock and take a purse string suture around the cervix and then tie a knot The knot can be anterior or posterior, and there is no difference in the outcomes with regards to the knot placement. Moving on to the Shirodkar cerclage, this is slightly more complicated because the suture is placed much higher up and it involves dissection of the bladder and the bowel. The cervix with a sponge holding forceps and apply traction. And then we do a transverse incision on the anterior surface and the posterior surface of the cervix. After this, we dissect the bladder of the cervix and we dissect the rectum also of the cervix. Then we take a suture as high as possible and go around the cervix. For this also, the knot can be anterior or posterior and there is no difference in the outcomes. After the suture is done, the epithelium may or may not be reapproximated. It is not necessary if the homeostasis is good. It's important to note, however, that if the knot, there are some advantages and disadvantages. If the knot is not buried and the epithelium is not closed again, removing the knot becomes easier, clearly, but the woman may have some bladder discomfort from the knot. Also, there are instances where the knot has been shown to be actually eroding in onto the bladder, and that can create problems for the woman. Also experience quite troublesome vaginal discharge. So if we bury the knot to try and avoid these issues with the bladder and the vaginal discharge, it is definitely much more comfortable for the woman, but removing the, we have to again open the epithelium and then find the knot and then remove the cerclage. Moving on to the transabdominal cerclage, this can be done either with an open procedure by laparotomy or by a laparoscopic technique. We can see the difference. McDonald cerclage is quite low down, Shirodkar's is slightly higher up, and the abdominal cerclage is quite high up at the level of the internal os. This is generally done for women who've got either a very short cervix or an absent cervix, or for women who've previously had a transvaginal cerclage, but it has failed. Whether the woman had a previous McDonald cerclage or Shirodkar cerclage, it does not matter because the studies show that after a failed McDonald cerclage, doing a Shirodkar cerclage on the next pregnancy is not necessary. You could directly go for an abdominal cerclage. And this can be done pre-conception or in early pregnancy. If it is done in pre-conception, it does not impact on fertility and the woman will be able to continue to conceive. Moving on to suture materials. Different materials have been used by different consultants. We can use a polyester braided suture, which is the Merceline, which is what this looks like, or we can also use Proline. There is one school of thought which says that monofilament sutures are more tissue inert. So there is a less risk of inflammation and less risk of infection. So that should be used in preference to Merceline. However, various studies have been done and none of them have shown any clear-cut results. The results are all mixed and there is no clear benefit of one suture material over the other. But it's again interesting to note that in most of the studies, history indicates emergency cerclages have been done with Proline because the belief is that the process of preterm labor has probably started. So there's already an element of infection or inflammation. So doing the cerclage with Proline is probably beneficial because it is more tissue inert and will not add to the inflammatory process. Coming to number of cerclages, how many should we place? Again, there have been various studies about placing just a single cerclage or whether we need to place 2 cerclages. And the studies have shown that there is no difference in the outcome. So a single cerclage should be adequate. However, if we are doing a rescue cerclage in a slightly more dilated cervix, we might need to do more than one. So we can use a first cerclage closer to whatever is accessible on the cervix safely, then use that as traction and apply a second cerclage slightly more proximal in a more optimal position. Post-operatively, once we have done the cerclage, the woman can be discharged once she's able to pass urine and she's able to mobilize comfortably. We generally advise to limit physical activity and to avoid coitus until about 32 weeks, but the evidence for this is limited. After the cerclage, the woman needs to have regular fortnightly reviews for cervical assessments. This can be done either with physical examinations, with regular ultrasound scans to monitor cervical length, or a fetal fibronectin test, which, if it is negative, will provide reassurance to the woman and the clinician. The reason why the woman needs to have regular fortnightly checkup is to understand if the risk of preterm birth continues to exist or if it is in fact increasing. And if we feel the risk of preterm birth is getting worse, then we would be able to time the use of steroids, use Maxelf if necessary. We would even consider admission or even transferring the woman to a place where NICU facilities are available for that particular gestation, so that we can provide the best facilities available for the baby. Then, if the pregnancy goes well of the suture, this is generally advised around 37 weeks because that is full term. However, if the woman goes into labor, so preterm labor, obviously we would have to remove the cerclage. McDonald's cerclage can be removed in the room, ward, or in the delivery room, but to remove a Shirodka cerclage, we would need access to the OT. If a cesarean section is planned, like say for a placenta previa or for a breech or for some other indication, the Shirodka cerclage can be left in situ for a future pregnancy. And if the woman has a transabdominal cerclage, this can be left in situ and the patient is delivered by a cesarean section. Removal of the cerclage after preterm pre-labor rupture of membranes is slightly more controversial because leaving the cerclage in versus removing it both have certain benefits and disadvantages. We know that if we remove the cerclage, that would mean on the gestation when the woman actually ruptures her membranes. If the pregnancy is less than 32 weeks, then we try as much as possible to retain the cerclage, but this is provided that there is no evidence of infection. There have been various studies, there have been only one study, which is just one RCT looking at whether we should be removing the cerclage or retaining it after PPRN. And the number of patients that were recruited was quite small and the study was underpowered for any outcome. So the general consensus is that yes, retention of the cerclage would increase the risk of infection, but if the pregnancy is less than 32 weeks and there is no evidence of active ongoing infection, then we would carefully monitor the patient for any signs or symptoms of infection and retain the cerclage for as long as possible. If, however, the pregnancy is over weeks or there is any evidence of infection or chorioamnionitis, the advice is to remove the cerclage. Complications of a cervical cerclage, like we can see with an elective cerclage, complications are quite low, whether it's membrane rupture or risk of infection. With an emergency cerclage, the complication risk is quite high. The risk of membrane rupture is up to 65% and the risk of an infection is up to 25%. These are the more common complications. Other complications that we can see in pregnancy, cervical trauma, especially if the woman goes into preterm labor with the cerclage in situ, cervical dystocia in about 5% of women, and sometimes bladder damage during insertion of the cerclage. Rare complications for which there have been only a few case reports are uterine rupture, severe excess bleeding at the time of the cerclage insertion, and very rarely a fistula formation with the bladder. In spite of all these complications and risks, we generally prefer to put in a cerclage for women at risk of preterm labor because studies show that we can reduce the risk of preterm birth less than 34 weeks by up to 23%, which is very significant. And we can also reduce the risk of perinatal loss by 18%. But outcomes would vary depending on the clinical setting, whether it's an emergency cerclage, elective cerclage, gestation, etc. Thank you.
That was a wonderful talk, Dr. Hima Bandhu. Actually, Hima Bindu, okay. Actually, I am a die-hard obstetrician and I have done so many of these cases in which I have put cerclage. So I have a lot of my own experiences which are there in journals also now. So like as a suture material, since I don't know, for the last 30-35 years, I've been using wool, you know, the ordinary wool with which we knit cardigans. That wool, and I autoclave it after threading it through a needle and autoclave it, and I passed. You know, the advantages of the wool have been that it does not cut through the cervical tissue. It is also quite flexible, because I had this case of twin pregnancy in which the first twin was cephalic and the second was transverse. So what happens, labor pains came, and before the patient could come to me, the first twin was already coming out. I got scared. I thought, oh my God, normally the cervix would have torn. Nothing happened. The wool just gave way, relaxed, and the baby came out smoothly. But after that, what happened? After that, in the second one, suddenly there was PROM and cord prolapse. But since I was smart enough to call the anesthetist, he was already there. So immediate cesarean saved the second twin also. So I found this very advantageous. And regarding Shirodkar stitch, I have seen my professor in GSVM Medical College way back in 1979. You know, she used to perform Shirodkar, and she had learnt it from Dr. Shirodkar himself. So she used to do it so beautifully, and we had these 2 aneurysm needles, and she would make a cut, reflect it. She was, I mean, one of the most deft and wonderful surgeons. And then 1 aneurysm needle she would put the way initially, you know, Dr. Shirodkar used to do. So that way, I have seen this procedure and I was totally fascinated by it. And one thing good I have realized is that once you do a cervical cerclage, the next pregnancy, I have never had to put it again, probably because fibrosis occurs in the cervical canal, and the patient never had any problems, but I gave her prophylactically progesterone. Vaginal progesterone support was given, and she never really needed it. In our time, when we started putting cerclage, progesterone, vaginal progesterone concept was not there. We were just on duodenolons and Dufeston and, you know, in our times. But now with the advent of coming of age of progesterone, it has become much better. And then regarding rescue cerclage, I would like to say that mostly it fails. I have only done it in 1 patient. And I tried everything under the sun, raised the pelvis. She already was in labor, 4 centimeters dilated, bag was bulging, everything I tried. Follies and everything. And finally, when she aborted, you know, it was such a heartbreak for me also and for the patient also. So rescue cerclage should actually, we have to do a lot of counseling before we go in for that. Because the process of abortion has already begun. So, and that was a wonderful talk that you gave, Hima. I think you covered practically everything. But if it is PPROM, I mean, if it's PPROM, I think I would try to remove the suture only, because that could be inviting trouble, you know, if infection does go in, which is very common. So I would really not wait for that. So
the patient has a, you know, stormy postnatal period if the stitch is there.
So I would not agree. I would remove the suture there and then. And any other comment?
Very nice talk, Hima Bandhu. You covered everything very nicely and in a practical manner. So just taking the cue from Ranjana, you used wool and I also use silk.
That is what I was also
silk.
Where did you get this idea about
We usually use silk. I use silk, and that is also braided silk, and that is also quite a good, like you said, gives way. It's a natural fiber, so it helps.
And doesn't cut through. Exactly. Yeah. With Proline, I would always be scared that it will cut through.
Yes.
But then I have not used it. So I can't be, I would not like to be biased.
There's a limit to the sensibility. There's a limit to its stretching. Does it break? Has it broken ever?
No, never.
पतला होता जाता है.
हाँ. अरे जैसे स्वेटर भी तो खिंच जाता है ना. But it gives a very good response, you know, and it's practically free of cost, and we just autoclave it like we autoclaving the other things and just put it through. So
how did it come to your mind? How did it come to your mind to use it?
I have seen my professor use it.
Okay.
In GSVM, our professor used to use it.
Okay.
And she used to do Shirodkars with that.
Oh.
Yeah, and I started doing McDonald only with that. But it was a routine over there. Like our professor only used it, not the other teachers, but she was using it. And so that gave me the courage when I went into private practice to start with wool. I started Sarklaj with wool only.
So this is what teaches us, like a stitch in time doesn't save 9, but it saves a lot of heartbreak and gives hope to the way. And it was a very comprehensive talk, Dr. Hima Bindu.
Yeah, Hima gave a lovely talk. Lovely talk.
Lovely talk.
Yes, I would like to mention one thing that about Sarklaj, it is very important to select our cases properly.
Yeah.
It's many a times we could have used, we haven't. Maybe because we are not adept, or maybe we are scared whether to do or not, or maybe we have overused it also. Like Ranjana said, emergency Sarklaj, I think rescue Sarklaj doesn't work so well but we have to choose the cases.
I have a relative whose son has done, now he's done his graduation and all, and it was an emergency. The membranes had collapsed out. It was in KGMC. And the membrane prolapsed. They put her in a head down position.
Dr. Madhu, maybe what had happened is that she wasn't in active labor, maybe. Because my patient was in active labor. She was screaming in pain when she came.
Yeah,
and another thing I wanted to ask you, Tulika, have you ever had to repeat a Sarklaj the next pregnancy?
No, I agree with you on that point. Yes. As it is preterm, the mid-trimester losses have a better prognosis with increasing gestation, pregnancies, number of pregnancies. So that is one cause maybe. And then the fibrosis, which you were talking about.
Yeah.
That also
I presumed it is fibrosis because, the cervical length also did not decrease. So I said, cool, as long as it's all right.
Yes.
But then also I had counseled the patients. This happened in 2-3 patients of mine. I had counseled her that, see, maybe you may need an emergency stitch then. She said, okay, I'm willing to take the risk. So I got her to use vaginal progesterones. So that helped maybe.
Here comes the empathy part, where you have to connect with the patient and talk it to.
Of course, counseling is always very important. Very important.
Because maybe rarely, but then the Sarklaj itself may cause a complication. So while doing it, however expert we are, so counseling also becomes important for that. Okay, I think we can wrap up the session.
Yeah.
Wonderful talk.
Nice meeting you all.
Nice.
Thank you very much, experts. It's a pleasure listening to everybody. And now I thank Dr. Hima Bindu for a very informative talk. Thank you so much. Now, after a very informative session, we move on to another talk that is about preterm premature rupture of membranes, key interventions for optimum outcome. To grace the occasion, our experts are Dr. Chandra Mansukhani. Can we have the CV? Yeah. Madam is senior consultant and in charge of adolescent clinic at Sir Gangaram Hospital. Madam is president ISOPARB Delhi chapter from 2021 till date. She is vice president IMS Delhi chapter, has been secretary NARCHI Delhi chapter, and has been treasurer and joint secretary in the past. Her specialty is in endoscopy and robotic surgery. We welcome you, ma'am. Then Dr. Anju Parira. Madam is director and senior consultant at Mother Care Hospital. She is president ISOPARB Bokaro chapter. She has been VP, secretary, and treasurer in BOGS. She's organized health awareness programs in many schools, and her area of interest is infertility and adolescent health. Then Dr. Vijay Anand Jamalpuri. He is consultant, neonatologist, and pediatrician, Rainbow Children Hospital, Hyderabad. He is president of PediStar, that is Pediatrics Simulation Training and Research Society. He has done various trainings in UK and New Zealand. His area of interest is simulation, point of care ultrasound, and neonatal cardiology. We welcome you, sir. I welcome Dr. Bismoy Sarangi, who will be speaking on preterm premature rupture of membranes, key intervention for optimum outcome. I request Dr. Chandra Mansukhani to please introduce our speaker, Dr. Bismoy Sarangi.
Thank you, Dr. Ritu. First of all, I would like to congratulate Dr. Sadhna and her team for a wonderful webinar on covering the important topics and making me the part of this important seminar. Thank you, Dr. Sadhna, and congratulations. So I invite Dr. Bismoy Sarangi. He's ex-assistant professor at Medical College, Raigad, Chhattisgarh. And at present, he's working as a consultant at Vikas Hospital, Sambalpur, Odisha. And his interest in the laparoscopy and he has a fellowship in the laparoscopy. So I invite Dr. Bismoy Sarangi to speak on the PPROM key interventions for optimum outcome.
Madam, my best wishes to Dr. Sarangi Bisma, because he is my student. Therefore, I am here to listen to him, and it is a proud moment for a teacher to listen to his student in such a huge seminar and with a high quality seminar.
Sir, he must be excellent orator and must be excellent student because he's a excellent, has a good teacher and excellent teacher. So why not?
Welcome. Thank you, ma'am. Yes, Bisma.
Good evening, everyone. I think I am the participant in this webinar. Am I audible?
Your
voice is not clear.
Your network connection is a bit patchy.
Yeah.
Bisma, you keep your video off and start sharing so that I think that will help a little bit. Voice was breaking actually. So keep video off for a while and start sharing and it will come up, I think, in a due course of time. निशा आपने उनका प्रेजेंटेशन बिस्मॉय ने भेजा है ना शायद?
नहीं मैम, बिस्मॉय सर से नहीं मिला है।
अच्छा बिस्मॉय, you able to share the screen? Yes. Yes.
Is it visible now?
Yes.
Yeah. We can see your slides.
Is it visible now?
Yeah,
it's visible.
Make it full. Make it full.
Quite visible. You carry on, please. Yes.
Yeah. So, good evening, everyone. I think I am the youngest participant in this webinar. And thank you, Sadhana Madam, and a special thanks to my teacher, G.D. Sahu sir, for giving me this opportunity to speak here. So, straight away coming to the topic, the topic today is preterm premature rupture of membrane, key intervention for optimum outcome. So, this is like a clinician's dilemma, because PPROM, as we all know, when to intervene and how to intervene and when to deliver. It is always a clinician's dilemma. So myself, Dr. Bismoy Sarangi, I am a consultant in Vikas Hospital, Sambalpur, Odisha. So briefly, just going into the introduction and the etiopathogenesis a bit. PPROM, as we all know, preterm premature rupture of the membranes. It is the rupture of chorioamniotic membranes before 37 weeks of gestation. And if it is before,
Bismay, your slide is not moving at the moment.
And Dr. Bismay, you can make it full screen.
Yes, and then
then it will move, I think.
Make it full screen.
Yeah.
Yes, fine.
Now it's okay.
I think not yet full screen.
Make it full screen. Yeah. Dr. Bismoy, make it full screen and then keep on moving it.
निशा आप हेल्प करिए थोड़ा वो ये नीचे जो ये वाला है ना दिस ये पुट ऑन इट anybody it is visible also you can go ahead I think
I think he's muted.
अरे रितु एक बार फोन करो उसको बिश्नोई को इंटरनेट का प्रॉब्लम है या there is any other issue. Bismay is here.
Yeah, I think now it's better. I think. But we can't see his slides.
Slides have stopped, sir.
I think Dr. Bisma, you can mail your site to Nisha and she'll share it from her end.
Yes.
I think he can carry on. It's okay.
Carry on. Bisma, to you carry. Yes.
Bisma, can you listen us? Can you hear us?
I can listen, but I think the slides. Yes, madam, I can hear you.
It's okay. You can move on yourself, and it's okay.
It's okay. Move. Go ahead.
So you off your video.
Nisha, are you there?
Yes, ma'am, I'm there.
Nisha, please check it out. Help him out.
Yeah.
उसका internet का problem है.
Ma'am, there is internet का connection का issue है, ma'am, because sir का connection बहुत poor है.
This way, can you or you mail it to Nisha, na?
Yes, if
it is possible.
Dr. Bisma, mail it to Nisha and then you join with your mobile. I think it will be better.
So you are there? Sir, I guess.
Dr. Ritu, you can phone him. Nisha, are you there? You can phone him so that he can mail you his slides.
Ma'am, I have shared the, okay, ma'am.
I've called him up. He's saying that he'll continue within a minute.
अच्छा ठीक है. Stop share. I think one he should rejoin, na? अच्छा Ritu, by the time Vismoy is joining, can we have some discussion like what a concluding remark or something? But actually, slide, no, but the slide is there. Actually, stop share the. That's okay. It's difficult to have discussion. निशा को बोलो हेल्प करने के लिए.
Hello.
हाँ, yes.
Yes, madam. There was some net problem, I guess.
अभी कैसा है?
हाँ, अभी ठीक है मैडम. ठीक है मैडम.
जल्दी से करो.
Carry on. Yeah, there's no issue.
हाँ, जल्दी करो.
So you try to share the presentation.
Yeah.
Or else you can share it to me, to my email ID.
Yeah, madam. So the risk factors.
हाँ, ठीक है.
Is the slide visible now?
हाँ, yes.
Yeah, it's visible.
Yes. You carry on, please.
Yeah. So the different risk factors, as we all know, the past history always repeats itself. So previous history of PPROM, any vaginal bleeding, smoking, and deficiency of vitamin C. As we all know, vitamin C is an important component of collagen synthesis. So deficiency of vitamin C, any previous operations on the genital tract, low BMI, illicit drug use, and various genetic factors. So different organisms involved are Trichomonas vaginalis, Group B Streptococcus, Chlamydia trachomatis, Neisseria gonorrhoeae, Mycoplasma hominis, and Uroplasma urolyticum. So there are different consequences of PPROM, but as we all know, the most common consequences are related to the fetus only. So, and if the disease progresses, then slowly and steadily the mother condition is also affected. So basically the consequences are the neonatal sepsis, chorioamnitis, endometritis, abruptio placentae because of sudden loss of amniotic fluid, pulmonary hypoplasia, decrease in the amniotic fluid volume, fetal compression syndrome, again due to the same reason, fetal growth restriction, and sometimes also fetal death. So coming to the initial evaluation of PPROM. So initial evaluation of PPROM with regards to the gestational age is very important, and that is because we need to know the exact timing of delivery and the exact timing for the administration of the corticosteroids, and as also the estimation of the fetal weight and also the presentation to decide upon the mode of delivery. So, and we also need to evaluate the risk of infection and also assessment of the fetal well-being in general. So there is also one condition that we should keep in mind, that is FIRS. What is FIRS? FIRS is fetal inflammation response syndrome. It is characterized by elevated levels of interleukin 6 in fetal blood and also matrix metalloproteinase 9. So this condition FIRS, it is associated with severe neonatal morbidity and shorter delivery timing. And it is also associated with long-term sequelae of bronchopulmonary dysplasia and also brain injury. So how do you diagnose PPROM? A simple sterile speculum examination is enough. So there is a big no to repeated PV examination unless it is for assessment of progress of labor. As also we can also do nitrogen paper test which changes from yellow to blue, and also Ferning test. When the amniotic fluid that is collected from the vagina, we allowed it to dry on a glass slide and we will see the Ferning pattern. Now there are different warning symptoms which we should not ignore, and the warning symptoms requiring urgent intervention are maternal hyperpyrexia of 38 degrees Celsius, more than 38 degrees Celsius, fetal tachycardia of more than 180, foul smelling vaginal discharge, and also severe pain lower abdomen. So these are the symptoms we should not ignore, and usually this warrants immediate and urgent intervention. Now, how to diagnose intrauterine infection in PPROM? One method is amniocentesis for the evaluation of the microbiological status of the amniotic cavity as well as the fetal lung maturity. But this again is controversial because already PPROM, already there is a break in the membrane, chorioamniotic membrane. Now giving one more another iatrogenic tear in the chorioamniotic membrane, it is debatable. So these days there is a better alternative and a much more advanced alternative, and that is advanced sonographic imaging. where sonographic identification of the functional and the anatomical changes associated with FIRS has been reported in the fetus heart, thymus, kidney, adrenal glands, and also the spleen of these fetuses. As also these days we can go for advanced MRI. So advanced MRI technique has now enabled assessment of cortical folding and subtle white matter injury of the fetus, which may be useful with regard the timing of the delivery or the therapeutic interventions. MRI may also aid in the diagnosis of pulmonary hypoplasia with PPROM. So like everything has a solution, nature has a solution for itself. So fetus may play a role in preterm PROM to speed the process of labor as a defense mechanism against infection. So this is the fetus in a bid to get rid of the infection. This may play a role in PPRM and to speed up the process of labor. So coming to some of the recent updates in the management of PPROM. So like I said before, does the digital examination increase the risk of infection? A big yes. Once a cervical digital examination has been performed, the clock of infection starts to tick. And a sterile speculum examination is always better unless labor assessment is required. So unless we need to know what is the cervical dilatation, what is the station and all, and to assess the stage of the labor, we can always take care of the things with the cervical speculum examination, where the clear fluid can be collected and the proper diagnosis can be made. And coming to the antibiotic prophylaxis for microbial invasion of the amniotic cavity. So current standard recommends a 1-week course of ampicillin and erythromycin. Now there was some old school of thought that they said that the role of antibiotic was debatable, but here if the diagnosis of PPROM is confirmed, then we have to give a 1-week course of ampicillin and erythromycin. Now treatment in pre-viable PPROM. Pre-viable means less than 24 weeks. It is called pre-viable because normally in Indian standards the fetus is not salvageable. So as there is a high risk of maternal infection, abruption, late abortion, pulmonary hypoplasia, low neonatal survivability, so we can always give the patient an option of abortion. But still, if the patient wants to prolong the pregnancy, suppose the pregnancy is a very valuable pregnancy conceived after IVF and all, so we can give her an option of outpatient monitoring. So outpatient monitoring can be performed with a written consent, with the patient returning to the hospital if signs and symptoms of infection, labor or abruption emerge. Once the patient reaches viability, she has to be admitted in the hospital. And no, tocolysis.
Your slides are not moving.
Tocolysis is not recommended.
Yeah. Now it's moving. Yeah.
And the treatment options. So I was talking about the pre-viable PPRM between 24 weeks. So as there is a high risk of maternal infection, so abortion, we can give an option of abortion to the patient. But if still the patient wants to prolong the pregnancy, then we can go for conservative management, but with a written consent about the future infection chorioamnitis that can develop, and the patient can return to the hospital if signs and symptoms of infection, labor or abruption emerge. And once patient reaches viability, she has to be admitted. And there is no role of tocolysis. Now the treatment option between 24 to 34 weeks of gestation, the current concession is to manage expectantly if no maternal or fetal contraindications exist. But in no case should the pregnancy be allowed to extend beyond 37 weeks. Now coming to the role of corticosteroids, as we all know, we give betamethasone or dexamethasone for fetal lung maturity. So a single course of corticosteroids, whether betamethasone or dexamethasone, is recommended between 24 to 34 weeks. There is no evidence that a single course of antenatal corticosteroids is associated with an increased risk of maternal and neonatal infection. So one dose we can always give safely. Now again, the role of repeat, or sometimes we give the third dose, that is the rescue dose of corticosteroids, that is controversial, and if there is an active infection, that should be avoided. Now magnesium sulfate, as we all know, it is a drug of choice in eclampsia, but we also know that it can be used as a neuroprotector. So studies have shown that prenatal administration of magnesium sulfate, it has reduced the occurrence of cerebral palsy, especially in preterm babies. So American College of Obstetrics and Gynecology recommends that magnesium sulfate for neuroprotection, it has to be given, it should be given before 32 weeks. And the dosage is initial 4 gram initial bolus has to be given for 20 minutes, and it has to be followed by 1 to 2 gram hourly for 24 hours. Now the role of amnio infusion, this is again a novel technique. The role of amnio infusion in PPROM, it can be of benefit by restoring amniotic fluid volume and cushioning the fetus to prevent mechanical compression. And it also have a dilutional effect. It may prevent intrauterine infection by diluent effect on bacterial concentration or antibacterial effects of the infusion. So we can always try amnio infusion in PPRN, but there is a big catch here too. If we give amnio infusion, it distance the patient. If suppose the patient is 1 centimeter dilated and we have to go through the cervix and give amnio infusion, then again it will fasten the delivery process. So again, this is a controversial thing. And if in my take is, if we are anticipating to to negate the infection, then only we have to go for amnio infusion. Just for the treatment of PPRM where the sepsis has not set in, amnio infusion I think should be avoided if we want to prolong the pregnancy. Now the mode of delivery. Induction of labor can be done if there is no contraindication to vaginal delivery, but careful labor monitoring is required because of the association between dysfunctional labor and intraamniotic infection. And again, liberal decision for LSCS can be taken taking into account prematurity. Now there are different novel treatment techniques that are that the clinical trials are going on, the studies are going on. Just 2 or 3 of them before I conclude my topic. One of them is amnio patch, where we give a transabdominal injection of platelets and cryoprecipitate. It helps in sealing the membranes. So ultrasound guided amniocentesis needle is utilized to infuse platelets 0.5 units and cryoprecipitate, which may form a plug and it seals the defected site. So this is one study that is going on, amnio patch. Second thing is fibrin tissue sealant. Similarly, the method is same, just the material is different. A mixture of thrombin, fibrin, and fibrinogen. It forms a fibrin clot that might prevent leakage of fluid at the site of rupture. It is also injected under ultrasound guidance, and it also helps in conservative management of PPROM and for better fetal outcome. Now, immunological supplements, it may stimulate the healing of membranes in PPROM because of increase in collagen and other synthesis. Physical barrier to stop leakage. This was a limited study. I think it was performed in Korea, where 16 women were given physical barrier to stop leakage. A cervical cup was used with negative pressure, but then again the results were limited, and the studies are still going on. Same thing also for absorbable gelatin sponge. So these are all the novel techniques where the treatment is going on to salvage the fetus even between 24 to 34 weeks of gestation. So just for a quick conclusion, timing of delivery in PPROM, it is still debatable. And how much to delay, risks versus benefits. So we have to see whether if the choriamnitis has already set on, the fetal tachycardia is there, then we have to deliver. So it depends on the clinician how much to delay, whether delaying is more important, whether delaying is advantageous to the fetus and the mother. And there is no general consensus on prophylactic antibiotics, but recent updates favoring antibiotic coverage. And there is no role of tocolytics, and judicious use of steroids and magnesium sulfate has to be used. Thank you, everyone. Jai Jagannath.
Thank you, Dr. Bismoy, for a very informative talk. I invite all our experts for their...
I think there were a lot of technical glitches. I apologize for that.
That is understandable. Nothing wrong in it. Yeah. I request all our experts to please give their concluding remarks.
Yeah, Dr. Bismoy, it was a very good and excellent lecture, to the point. But I would like to ask you, what antibiotic would you prefer? And what is according to the evidence, whether we should give antibiotic or not? Because you did not actually explain that thing. You said it favors a favorable outcome, but what antibiotic should be given, for how long it should be given, and in what cases it should be given?
Yes, madam, I mentioned one of we can, yeah, we can erythromycin combination, madam.
Okay. Only erythromycin, or you give the azithral and then you give the ampicillin, or only erythromycin? For how long?
Why you can stop slide share so that we can have a discussion.
Yeah, I think.
You stop slide share so that we can have a good discussion.
Dr. Bismoy, can you hear us?
I think again it's connection.
There is a connection problem actually.
Yeah.
Yes.
Dr. Bismoy, can you hear us?
Chandra, you can give your remark for the antibiotic use. That is very, very important actually. That is
So,
very, very
so I think we should give the GBS coverage also, and we usually start, and even the evidence suggests that. Pardon? Pardon?
Yeah, it is always better to give GBS coverage, madam.
Yeah. So we start with the azithral. Start with the azithral 1 gram and followed by the 2 gram.
We can start. Yes, madam. We can start with azithromycin, but to cover the GBS also, we are giving erythromycin. So erythromycin, we can give a substitute. Azithromycin can also be given in place of erythromycin. So no problem with that, madam. But GBS coverage, yes, erythromycin and azithromycin both can give.
Yeah. Yeah. So we should start with the azithral followed by the ampicillin injection and erythromycin. Or
madam.
We can give the ampicillin later on capsules also, amoxicillin plain, not the cavulanic acid. Is it okay, Dr. Bismoy?
Yes, madam. If the patient is like outpatient, we can start with oral tablets. There is not always indication for injectables. Even oral tablets, antibiotics can be good.
Yeah, we can give the oral also for the minimum 7 days. But where it should not be given, Dr. Bismoy?
Yes, madam. 7.
No. What are the conditions where we should not give the antibiotic? I think in all the PPROM cases, we should give the antibiotic. With the intact membranes, we can avoid the antibiotics.
There is only preterm
Yes, madam.
labor.
Sometimes what happens is
brain is intact. In that condition, we have no need to give antibiotic.
Yeah, Dr. Anju, definitely, yes. Intact membrane, preterm labor, we can avoid.
Is there any role of clindamycin and metronidazole?
Yeah, suppose it is not a confirmed case of PPROM, suppose
there is a lot of
it is not a confirmed case of PPROM, because sometimes patients do come. Sometimes patients do come complaining that they are having leakage per vacuum, but it is actually not there. So proper diagnosis is important. So if by diagnosis we rule out that there is no PPROM, then I think there is no role of antibiotics. In that case, we should avoid any antibiotic.
Yeah, absolutely. You are right, Dr. Bismoy. We have to first confirm the diagnosis. By whatever the method, you have to confirm. You can do the ultrasound, you see the Likert, and you see the history, you do the per speculum examination with the sterile speculum, avoid the PV examination, confirm the diagnosis, and then you decide your management, and then you give the antibiotic. That is, and you have to decide the steroid course, and the plus you decide the timing of the delivery, and whether you want to prolong, you give the tocolysis or not according to the gestation age only. So you have to confirm the gestation age, you have to confirm the diagnosis, and then only you have to counsel the patient, take the neonatologist's opinion, and see your NICU facilities, whether your NICU facilities are very good to look after the very young fetus. Then you have to decide the timing of the delivery. So I think you covered all the points. And Dr. Anju, you would like to give the inputs?
Yeah, just I want to add that tocolysis is required only to extend the effect of the steroid should occur 24 to 48 hours. only in that condition. And we should always,
As per steroid coverage.
according to the gestational age and the need of delivery, we must always take call of our friend, neonatologist friend, because the preterm baby delivered in the presence of the neonatologist, so that postnatal care of the baby, neonatal care should be taken by them. The body temperature regulation, infection control, feeding, and all those. So hand to hand with obstetrician, neonatologist, yeah, facility of NICU must be there if early preterm babies are going to be delivered. And Mr. Vishnoi, Dr. Vishnoi, your talk is very elaborate and cover all the topic. So it's a nice presentation.
And
Thank you very much.
we have our pediatrician friend Vijayalan for
We
his comment what he wants from obstetrician, so that they get the optimum newborn health. So Vijayalan, what you want expect us from all of us,
yeah,
in the case of PPR.
I would like to give his opinion, because he would love to get the mature fetus rather than the preterm fetus, and even in the late preterm fetus, he would love to give the fetus up to carry the pregnancy up to the 37 weeks.
Pediatrician delivering the
what is
from obstetrician.
Dr. Vijay Anand, sir.
Absolutely, ma'am. Absolutely. Good evening, all. First of all, thank you, ISOPARB team, giving the opportunity. It's always been a pleasure to be within these webinars, and excellent, succinct talk by Dr. Bismay. And yeah, absolutely, the best place for the baby to be in the mother's womb until they are ready to come. But unfortunately, it doesn't work all the time. So as long as possible, you keep, and as Madam rightly said earlier, you want to ensure that have you got a facility to look after this baby in case it's going to deliver. The best way and the best mode of transport for a premature baby, potential premature baby, is in utero transfer. So if you think there's a likelihood of delivery, and when the conditions are under control, I rather refer this baby where the facilities are available based on the prematurity level. So there are level 3 care for extreme prematurity, some level 2 care for moderate preterm, which is after 32 weeks, and level 1 small units can also look after late preterm. So depending upon that, you can one. The second thing is that I also heard the good discussion about the antibiotics. From neonatologist point of view, we want you not to give coamoxiclav. I think Madam already mentioned that very nicely, because there is association of necrotizing enterocolitis in preterm babies when coamoxiclav being used. So we don't know causation, but there's a definite association. So I would do that. Third thing you already nicely discussed is getting that steroid coverage. A complete steroid doses of 2, and if you go with the Indian government guidelines, dexamethasone 6 milligrams, 12 hours apart, 4 doses, and if you leave it 24 hours long, maybe I'm too ambitious, and that would be good for the baby. And then of course we already discussed, and the steroids, as you know, decreases the RDS, decreases the necrotizing colitis, decreases the death as well, and also IVH. And when it comes to the magnesium sulfate, and nicely you have showed us the dosage pattern. There are variable doses, but the one you suggested is the most commonly used. We want the babies to receive as much as possible, even if it is not, you given the loading dose, you given 1 gram per hour until at least up to 24 hours or the delivery, whichever is earlier. And this has clearly shown the decreased incidence of cerebral palsy. Number need to treat is around 25-30. And so those are things we want. But again, you want to balance the baby to be inside or to come outside. So if there are indications of any fetal inflammatory response, that means baby is being compromised, or for maternal reason, if the mother is having a serious chorioamnitis, you need to terminate this pregnancy. Yes, he needs to come out, then he has to come out. But so you have to weigh the benefit and the risk, because the best place for the baby to grow in the mother's womb, but the best place becoming not the optimal place for the baby, has to come out, and then you have to offer some work to us. Then we can assure you to some extent whatever we can do and provide. But just because you have a facility to look after premature babies, they should not come out. At the same time, if this is a compromised fetal condition in the fetus, then they have to complain. Again, this, as Madam rightly said, a continuous partnership and dialogue with your pediatric colleague, and of course, and the partnership with parents in the decision making is equally important. I think that's all I want to say. And generally, what we do after all based on the prematurity, they are prone for respiratory distress syndrome. They are prone for infection, and of course, all the other complications of the prematurity. I won't necessarily discuss everything here. And based on the prematurity, one other important thing I want to emphasize here is hypoplasia of lungs. If the rupture membrane is before 28 weeks and the liquor is less, or if the prolonged rupture in membranes with the low liquor for more than 2 weeks does cause lung immaturity. It will, because you need the fluid for the, as you know, the lungs to develop. So one of the things we keep in mind when we counsel these families, not only the counseling about the prematurity complications, we extra add a hypoplasia of lungs based on how early the premature rupture of membranes, how prolonged it is. We want to, because we do see some of the babies who do really poorly and become very sick respiratory wise because of the hypoplastic lungs, and some of them don't even make. I'll stop it there. I think I said a lot.
Dr. Anju and Dr. Sadhna, I would like to ask that how many gynecologists or how many we all are, whether we are doing the amnio infusion in cases of PPROM?
So amnio infusion, a lot of paper, but all over the world has refuted its implication, and it has not been found effective. It can itself produce infection, and itself can be the cause of choriamnios.
So I think we are not doing
no amnio infusion.
I had never done in the PPROM.
So we were quite intelligent, and we didn't succumb to all in practical studies. And if the world has been on the went page,
I thought the other people are doing.
No. It is not recommended. Maybe doing or not doing, but it is not recommended for anything. Even for meconium aspiration, what we say intrauterine, it is not.
There's risk of the infection. And magnesium sulfate, if fetus is less than 32 weeks, gestation is 32 weeks, then only after 32 weeks, we are not giving magnesium sulfate for the neuroprotection.
I mean, some of the studies, Magenta trial has seen even up to 34 weeks. But I think 32 is a fair thing. Yeah.
Magnesium sulfate is a tocolytic as well. So a little bit hypertension, then it is also to magnesium sulfate is okay. But what you say, even after 32, 33 week, we are not giving.
We are not giving.
And again,
and recommendation is also like this.
No, one thing.
Yes, Anja.
That is their role of corticosteroid in the late preterm 34 to 36 plus 6 days, whether it should be given or not.
Now, according to the RCOG, according to the RCOG, if you are doing the elective cesarean, then you should give. But if patient is going in the spontaneous labor and you have planned the vaginal delivery, then I think after 34 weeks, it has not much role. So what is your opinion, Dr. Vijay?
Yes, ma'am. So yes, madam, the RCOG, ACOG guidelines both recommend in case of elective cesarean up to 39 weeks. But having said that, the most recent data concerning in the sense there's an increased risk of hypoglycemia. So we stopped that practice and we discourage any active delivery unless otherwise it is indicated in that category of late preterm deliveries, madam. So, but of course, if you need to do for a right indication, absolutely.
Yeah, less than 37 weeks if we are doing the elective cesarean, not the normal cases, but in case of the PPROM then we are giving the steroid.
Yes,
but after 37 weeks, we are not giving steroid.
Yeah, even after 34 also the evidence shows the increased incidence of hypoglycemia. And unfortunately, hypoglycemia can cause significant neurological morbidity. However, the evidence also shows that giving a steroid in 34 to until early term also can decrease the respiratory morbidity. So, but majority of time, what I would say as a pediatrician or the neonatologist, these respiratory distress is not significant. Yes, one in off. So you have to weigh that balance. Do I put them to the risk of significant hypoglycemia or do I put them in respiratory morbidity? But we stopped doing that, madam. Now we were giving until recently as the new data emerged about the concerns of hypoglycemia. But I understand still RCOG has not changed the guideline. I agree, madam.
Yeah, but we are not giving otherwise after 34 weeks.
Yeah.
And one thing important, which we always, if there is a significant leukocytosis or a sepsis, then again the steroid, actually once Chandra was saying antibiotic, actually PPROM is the condition where antibiotic should be given. Or for the maternal sepsis and for the neonatal sepsis. It is the condition where we should have a good coverage and what we are GBS like prophylaxis or the MP metrogyl. So this is the condition when the neonatologist also want that the mother should be given antibiotic. That is the passive protection. And Vishnu, one concept about that, the three categories of the chorioamnitis. One is only clinical. Second is confirmed by lab test. The third is histological proven. And that also gives quite a bit idea how aggressively we should manage PPROM. So this is the concept which actually helps in the clinical practice.
Yeah, so, absolutely. Absolutely, you are right, Dr. Sadhana. So it was a very good lecture, Dr. Bismoy. Thank you very much.
Dr. Gangadhar Shah wants to say something. Yes, sir. It is a concluding remark session.
No, madam, regarding this discussion, first thing is routine administration of steroids. So the latest guideline is if you are preparing for an elective CS up to 39 weeks, you can give one dose of corticosteroid and that's enough. So there is no controversy about that. That's number one. Number two, the talk and the discussion of Bismay was fantastic. I think that Chandra madam was the external and he is the postgraduate student. In that way, a very good discussion. I could enjoy it. So thank you, Bismay.
But he was very good. He was well prepared.
I enjoyed it. And because of so second thing is antibiotic. Again, we are thinking of the prophylactic antibiotic, not necessarily as Sadhana madam said, the three categories. That is only after you test everything. But when a case of PPRMA comes in the labor room, there must be a standard protocol which antibiotic you are prescribing, particularly group B streptococcus. So that again, that is primarily we give antibiotics on that basis. Then we start with taking the vaginal swab or this, like coraminide, discharge, everything. And rightly she has said that internal examination should be avoided. Rather, even for speculum if it is required, or else to know the progress and the length of the cervix, your perineal ultrasonography is as good as the very good results, just like a PV examination. So that much I want to add in this discussion. And I enjoyed the talk of Bismay. So thank you, and also all the chairpersons very active part in this. Particularly, I am very happy with Chandra madam regarding this discussion.
Thank you, sir. Thank you.
We will be needing you, Chandra, and more Yuva, ISOPARB, because we want that a little tough discussion.
Thank you, sir.
I wish Chandra madam in majority of those webinars.
Sir, definitely. I would like to even love to be a part of every webinar.
Thank you. Very lively discussion. Thank you very much.
Thank you, sir.
Thank you very much, all the experts and the speaker. Thank you very much. Now I hand it over to Dr. Aruna Chapadia for question and answer session and for vote of thanks. Thank you.
डॉक्टर राधा जी ना मैडम का और मेरा कंक्लूडिंग रिमार्क छोटा छोटा है. So So I will just finish two things to be very practical. First, Bismoy has been cross-examined very well. Single embryo, what the fetal reduction is, so every mentor says that we should avoid. But in practicality, actually, even the every world recommendation, there are a selection of patients who are for single embryo transfer, like young patient who have the PCOS, and in elderly patient, thin endometrium, previous IVF failure, we have to do the double or the triple embryo transfer. That is the reality, because no IVF patient, like at the age of 37, 38, we don't have to failure. So we have to be ready with the fetal reduction technique. And the second important thing is that it is not that every triplet should be reduced to 2 or like 1. Because in my experience, if the patient desire, many times patients come back because they don't want to lose, like there is a risk of abortion, there is a risk of thing. And sometimes we really get 30 to 33 week size triplet, and sometimes we really have problem. So the patient decision should be taken. And to be very practical, why we kept this topic, that we cannot prevent actually. If we are having ART, even the simple clomiphene induction, simple 75 gonadotropin can cause the multifetal pregnancy. So we have to be ready with the techniques, with the referral and the good clinical practice, which Amrita has said. And a little bit about cervical cerclage, I think 1 or 2 points that like history indicated cerclage is as good as ultrasound indicated. And the cervical, gradual shortening of the cervical canal is very, very important. If it is there, then even if it is more than 3 centimeters, even then we should be careful that what we should do. A lot of things can be done for this cervical cerclage, and the laparoscopic cerclage is too much fashioned out. But I want to warn audience which are with us that it needs abdominal removal. So in case patient have the IUFD, or if patient have the something, the transverse lie or something, you have to do the cesarean section for the removal of the cerclage. So that is very hyped out by the laparoscopic surgeon, but actually the abdominal cerclage decision should be taken in a very, very, like it is an important decision which patient wanted. So this was my, and Dr. Radhajina, madam, your brief concluding remark before Aruna goes for vote of thanks. Aruna.
Thank you, Dr. Sadhana, for including me in this important webinar. All the 3 speakers were very to the point, and they were excellent, and they have not left more points to be discussed. And the chairpersons were also experts, so they have covered almost everything. They have made our job very, we can say, easy. So I will just be very, very short. Dr. Amrita has discussed all the things about fetal reduction, and this topic was not discussed too much in the webinar. So it was a, you can say, a good topic to be heard today. And the fetal reduction can be done in multifetal pregnancies, which is more common because of ART nowadays. And if it is more than 2 or 3 fetuses, then for a successful pregnancy, fetal reduction is needed. And it is either selective fetal reduction or multiple pregnancy, or it can be done just for the chromosomal or some genital abnormality in one or the other fetuses. So details Amrita has dealt very nicely. And the choreo in monochorionic twins, the fetal reduction is little more difficult, and it should not be done by chemicals, and it can be done by either bipolar cautery, or it can be done by intrafetal laser ablation, or it can be done by radiofrequency block. So this was about the fetal reduction. Yes, cerclage operation has been also covered nicely, and we all have done so many cerclage operation, and we know the results of cerclage operation in electives and cerclage are much better than when we do it as emergency and cerclage. Now the Shirodkar, modified Shirodkar, we have done early days 2 or 3. I have done only 2 or 3 or 4 Shirodkar and cerclage, but the McDonald cerclage has been done, and we are all doing this now. So the results are very good, and in elective it is about 80% we have a successful pregnancy, and the cerclage should be removed.
at 37 weeks, or if she goes in labor earlier. Now, yes, the abdominal enstrad, I have no experience, and I have not seen also the cases of abdominal encerclage, so I cannot comment on this. Now, as far as the PPROM is concerned, lot of discussion has been done, and the actual treatment depends upon when the PPROM has occurred. If it is too early, between 24 to 31 weeks, then the ideal treatment, we all know, is giving corticosteroids, and to my opinion, we should always give antibiotics. Now, if it is more than 34 weeks, then we can give these antibiotic corticosteroid, and we, if frank leaking, then we need not to prolong the pregnancy, we can allow delivery. But if possible, we should try to take the pregnancy up to 37 weeks so that the lung maturity is there and there are more chances of fetal survival. And our this petition has covered all the aspects, and we should ask these patients to go for delivery in such a hospital where the facility of an ICU and an expert neonatologist is available, so that they can take care of the fetus. And there can be so many problems which the only neonatologist can deal with. So there should be such a place where all these facilities are concerned, and then the fetal survival is better. So that's all I want to say. Thank you so much.
Thank you very much, Madam Sadhna and Madam Radhajina ma'am. Thank you so much for your valuable inputs. Now I request Dr. Aruna Chapadia to please give a vote of thanks. Dr.
Babita, you can give. I don't see Aruna here.
So today we had a very, very interesting session. Our first Yuva ISOPARB was also very interesting, and this was even more interesting with so much of valuable inputs from our seniors and elaborate talks from our juniors. I would like to thank Sadhna Madam for organizing such a wonderful webinar and then giving me the opportunity to take part as a coordinator in this webinar. I would like to thank our esteemed chief guest, Professor Gangadhar Sahu, who has been kind enough to give us valuable input. Sir has been present right from the beginning till the end and has been very active throughout the session. Thank you so much, sir. My sincere thanks to Dr. Sheila Mane and Dr. Milind Shah, our special guest and guest of honor. Their valuable inputs will really keep in our hearts, especially their take on reaching out to the poor and giving back to the society what we have learned from the society. I extend my thanks to all our chairpersons and also to our speakers who have really worked hard to give such an elaborative and informative talks. I would like to thank our experts, Dr. Sadhna ma'am and Dr. Radhajina ma'am, to give their concluding remarks and sum up all the three talks in such a beautiful manner. My thanks again. I'm sorry I'm not able to take the name of all the chairpersons because Dr. Aruna was supposed to give and I don't have the names in front of me. Please accept my apologies. Actually, I should be taking name of every chairperson and speaker, but then it is just an extempore talk. So please accept my apologies. And I would also like to thank my co-coordinator, Dr. Ritu Srivastav, for conducting the entire session, session 2 and session 3 in such a wonderful manner. My thanks to all the delegates who had joined this webinar. Without the delegates, our entire talk would have been futile. I also extend my thanks to the Corona Remedies team who has given us this virtual background, and the entire webinar was conducted so very smoothly. And our takeaway, apart from the talks of selective fetal reduction, cerclage, and PPROM, the talks from us, the takeaway from our seniors, the ABCD approach to our life by Professor Gangadhar Sahu sir, this has really touched my heart, and we will all try to follow it. And Sheila Mane ma'am's message that जैसे माँ का मातृ ऋण होता है, पितृ ऋण होता है और गुरु का ऋण होता है, तो हम लोग का सोसाइटी की तरफ भी ऋण है. We should follow our duties and we should give back to the society. And of course, Professor Milind Sahu, who has really gone out of his way, and he has done so much for the society, for the poorer sections. And Sadhana ma'am, who is trying really hard to reach each and every society to pass on her academic skills. Like ma'am is also doing a great work. Whatever she has received, she has absorbed over the years. She is dissipating knowledge is something we should always be free of cost. And that work is being done by Sadhana ma'am. Ma'am, hats off to you. And I really, really hope to see you in the highest position in Foxy. Our best wishes with you. So I'm really sorry if I missed out anyone's name. Because again,
Corona remedies, Nisha and Corona remedies.
Yes, I have mentioned, ma'am. Corona remedies I have mentioned.
Dr. Gangadhar want to say something.
Yes, so please.
Babita has missed one of the very important person's name. Therefore,
Yes,
on behalf of the whole of the team and as the president of ISOPARB, I should like to take her name, that is Babita Shukla.
Oh my God. Sir, thank you so much. Thank you so much.
Many thanks for coordinating and also anchoring and summarizing. So what a beautiful role you have played. Unique, really unique. Thank you very much, Babita.
Babita is always very good. He is very good, very good.
Thank you, ma'am. Thank you. Your words mean a lot to me.
Thank you, sir. आपने मेरा काम करा. जो मुझे कहना था
हमारी सोसाइटी की शान है ये लोग, हमारी सोसाइटी.
Thank you, ma'am. Thank you. Thank you. Thank you once again.
Society, madam. I am also a member of Gorakpur Society.
Yes, sir.
Yes, sir. Very much.
We will like to have everybody on at some place in physically Gorakhpur also. Vijaya and Anju, everybody, Chandra, we will really like to have you because in ISOPARB you were virtual, but next time we really want to have
I
you.
also Chandra madam in all webinars. So
Yes, sir. I would love to be. I will be there. Without inviting also, I'll be there.
Thank you.
You are a good teacher.
Thank you, sir. Thank
So,
you. Thank you, Dr.
Nisha,
Sadhana. Thank you very much.
Thank you.
Thank
Nisha,
you.
Thank you for being with us.
Yes, thank you, Nisha. You were a real support throughout, right from the beginning.
So, Nisha, we can say good night. Vijaya,
Good night.
good
So much, ma'am. Good night.
Okay, good night, everybody. Good night.
Thank you, Amrita, everybody who is with us in the faculty.
I'm here. Madhu is here.
Madhu is here. अरे आपकी आवाज को कौन नहीं जानता?
Thank you. लेकिन Babita, you were blushing as red as your clothes. मतलब वही color आ गया
Ma'am,
था.
I couldn't remember the name of all the chairpersons. I was feeling so bad.
इसलिए flush
मेरा
कर
तो
रही
याद रख
हूँ.
ले.
For that.
एक बबीता प्रिंट आउट निकाल के रख लिया करो हमेशा.
नहीं, मैम, एक्चुअली अरुणा जी को देना था ना, तो नहीं तो मैं सबका अपने सेशन का याद था.
You did justice. You did justice. Wonderful justice.
Yes,
Wonderful
thank
justice.
you, ma'am.
More than a justice. It was wonderful. So, Nisha, you can conclude. You can end the